Ready? Okay, I think we are going to start. Good morning, everybody. My name is Gil Mora. I'm the director of the CS Mott Center for Human Development. I really want to welcome everybody to this first symposium of our 50-year celebration. And since it's our 50-year celebration, I'm going to take exactly 2 minutes. That's what they give me to tell you about the Mott Center and where we are. So you are in this building. I was talking to Matt, and it's true. And so many people don't even know what is inside of this building. It has been a well-kept secret. The Mott Center has 24,000 square feet of laboratory space. That includes 3 floors. They were renovated first in 2011 and then in 2015. So it's a fully renovated lab space, and it's housing, as we're going to show you in a minute, research that is mainly focusing on human development, both preconception, pregnancy, and post-pregnancy. That is the life of the health of the woman, and that is the reason we have this strong group that works in gynecological cancers. And we wanted to start with that, with ovarian cancer today. So the Mott Center was established in June 14, 1973. So this is the year that we are celebrating the 50 years. Initially was designed as a center for the Department of OBGYN. In 1983, it was established as a university center. And in 1988, it was designed as an entity of the School of Medicine. This is a nice picture. In 1973, Mrs. Ruth Mott, who was a patient here in the OBGYN department, she decided to contribute for the research in women health and all the aspects of women health. And they donated together with her husband the money to build this building, who carries the name of the CS Mott Center. And you see the picture of the couple, the family Mott, who contributed for building this center. The first director was Dr. Tommy Evans, who was present at the inauguration of the center together with Ruth Mott. And here is Hardin Mott and Ruth Mott at the day of the inauguration. So this is the same picture that you see in the wall. What is our mission? The mission is to develop and promote personalized approach to medical treatments and care that improve the health outcome for women, men, and children in Detroit and around the world. That is our main mission. And in order to achieve that mission, we organize the center in specific areas. And you are more than welcome to visit the lab space in the breaks or at the end of the day. We will be delighted to give you and show you more details. But the groups that we have are a group on pregnancy and neonatology, male and female infertility, the oncology, and our generally the diamond that we have here is the clinical research center. This is the group of pregnancy and neonatology, is directed by Dr. Ramados. We have a combination of MDs and PhDs. We have the group of oncology that is directed by Dr. Alvero. The same, the group of male fertility directed by Dr. Pilsner. The female infertility directed by Dr. Rudant, and the CRC, we have 7 coordinators running 18 clinical trials that is directed for the former Dean of the Medical School, Dr. Jack Sobel. So we are delighted to have you today here. I just want to make some acknowledge, because this, as you can imagine, it doesn't happen easy without the help of a lot of people. First of all, I want to thank again MassMutual for the support of our activities. It's the second time that they come and they help us in our activities. Mayoka for the continuous support in the organization of this symposium. By the way, this is the first symposium that we will have it through the year. As I mentioned, we have a symposium in the month of November about pregnancy and women health, and another one in February about infertility. So if you are also interested in other aspects, you are invited to join us. individual helps, of course, Dr. Alvaro, who has been leading the organization of this symposium. Alisa, who is somewhere there, taking care of everything. If there is any concern or something, feel free to approach Alisa. George, who is also will be helping with all the problems with the technical, the computer aspects, and the whole members of the Mott Center who have been very supportive in organizing this first event in our 50 years. And with that, I want to thank also all the speakers for coming. Yeah, we are delighted to have you here, and we're looking forward to a fantastic day of science and learning. I finished with this, I promise you. I promise, Dr. Alvaro, this is my last thing. At the end of the day, around 6 o'clock, there will be a panel for asking questions. Those questions are not for you. Today, during the day, ask questions about the science, but please pass the word. At the end of the day, there will be a Zoom meeting for patients, friends, public in general. And the panel, who is the speakers and the doctors from our community, they will be answered questions to the community about ovarian cancer. So make sure that you pass the word that today at 6 o'clock, there is an open public panel responding questions. And with that, Dr. Alvaro.
Thank you.
George.
So good morning and welcome to the Mott Center. I am Ayancha Alvaro. I will be introducing the speakers for our symposium today. I am your first speaker, so I am introducing myself. As Dr. Moore said, I am a professor in the Department of OBGYN here at the Mott Center, and I belong in the Ovarian Cancer Research Group, and happy to welcome you all today. So I am going to share my screen. And I'm checking that, making sure that everyone on Zoom is able to hear. We don't have any chats here for now. Is that good? Okay, so for this morning, I want to tell you about the ongoing project that we have, wherein we perform transcriptomic analysis and mechanistic studies and demonstrated that there is a distinct molecular signature that differentiates BRCA1 and BRCA2 mutant ovarian tumors. So if you look at the cases per year in the US, which is the y-axis here, and you look at ovarian and you try to compare it with breast, lung, and colorectal, you can see that it's not really, or it's relatively rare. And even if you compare it with the rest of the gyn cancers, endometrial has the higher incidence, ovarian is only 7. However, if you look at the mortality, ovarian is the top, and it ranks first in cancer deaths from gynecological cancer. Sorry, Dr. Said.
Make it bigger.
George, can we make it bigger?
I think that's the maximum of this.
Is that the max?
Yeah.
Sorry. And it ranks 5th in cancer deaths in women. So ovarian cancer survival has unfortunately not really improved in decades. So if you compare with all cancers, even breast cancer or prostate cancer, that has seen about 20 to 30% improvement in survival rate from like 1975 to 2015, you can see that ovarian barely reached 10% improvement. And if you look at the trajectory from 2015 to about 2020, you can see that the line is pretty flat in terms of survival. But something that we observed is that when you look at survival rate sub-analysis, comparing a specific population that has germline mutation in BRCA2, you can see that it is separating, that there is improved survival in patients that have germline BRCA2 mutation compared to patients with wild-type BRCA1 or 2 and germline BRCA1 mutation. So BRCA1 and BRCA2 genes is something that we all know what they are. They are considered tumor suppressor genes. They both function in DNA damage response, and they both increase the risk of getting breast and ovarian cancer. The germline mutations account for about 5 to 10% of epithelial ovarian cancers, but you also see somatic mutations in about 5 to 7% of cases. So even though we know that both of them increase the risk for ovarian cancer, there are specific differences that we can observe, especially looking at the clinical profile of patients. We know that the penetrance is higher in BRCA1, 36 to 60%, compared to about 16 to 27 in BRCA2. The median age of diagnosis is younger in BRCA1 compared to BRCA2, 53 versus 62. And there are studies now that are coming up with the conclusion that BRCA1 patients are more resistant, meaning BRCA2 mutant patients are more sensitive to chemotherapy as well as immune therapy. And this is not just ovarian, but also for breast as well. So the scope of our research really is trying to understand the molecular mechanisms that may contribute to the better survival that we see in patients with BRCA2 mutation, thinking that knowing these molecular signatures, we can better understand disease progression. And maybe there is something that we can learn to molecularly, the molecular phenotype that we can maybe pharmacologically copy to improve survival. Because as you can see, you have the wild types and the BRCA1 mutations with 30–40% survival, and you have the BRCA2 here with 70% survival. So our group is part of the Janet Burrows Ovarian Cancer Consortium, and we have access to RNA sequencing that was done by Tempus. Dr. Radhika Gogoi and Dr. Song Ho Kim was able to identify about 626 patients that are homologous recombinant wild type, meaning they are wild type in all of these homologous recombinant associated genes that's listed here. 15 that is somatic mutation, or more specifically loss of function mutations in BRCA1, and 16 with loss of function mutation in BRCA2. So we took the transcriptomic data and performed, or here I think it's actually showing that in terms of age, race, and stage, there is really not much significant difference between the patients. So from the transcriptomic data, we obtained differentially expressed genes. We have 3 groups. So you can see here the 3 different comparisons between the group. And you can see here the volcano plot, which basically just shows that if you compare one group to the others, we can really see differentially expressed genes that are either upregulated or downregulated, suggesting that, yes, you can see some molecular differences. But to make more sense of these differentially expressed genes and how they are related in biology, so we performed pathway analysis, and what you can see here is the pathway analysis specifically comparing BRCA2 to BRCA1 mutant. You can see the top 10 differentially regulated pathways here, which are color coordinated on this side. And you can see the genes that are within these pathways on this side organized into the most upregulated and the most downregulated. And what you can see here is majority of the genes that are upregulated belong in the Wnt signaling pathway, and majority of the genes that are downregulated, what is that color, is the metabolic pathway. So with these, you can see pathways that are very general, pathways in cancer, breast cancer, metabolic pathways. And so for us to try to determine which one we will validate, we then performed the Venn diagram analysis and identified 6 pathways that are unique to BRCA2. And these pathways include peroxisome, oxidative phosphorylation, Wnt signaling, thermogenesis, Parkinson's disease, and Huntington's disease. So we further did a network analysis and identified that out of these 6 pathways, 5 of them form a network. So all of the pathways that are marked with the rest asterisk have 11 common genes, and all of them are downregulated in BRCA2 mutant tumors. When these genes are formed in network, we see that they are all involved in NADH dehydrogenase activity, which is complex 1 of the electron transport chain. So the other thing that we did was perform meta-analysis for differentially regulated biological processes. And here we identified around 331 differentially regulated biological processes that's unique to BRCA2 mutant tumors. We see a lot of processes that's related to development and morphogenesis, which is probably due to the difference in Wnt signaling that we saw on the Wnt pathway. But in addition to that, we saw a lot of terms that's related to immune cell differentiation and commitment, as well as antigen processing. And so you can see here antigen processing and presentation via MHC class 2, proliferation of the myeloid compartment, differentiation of the myeloid compartment, and commitment of the T cell lineage are all differentially regulated when we compare BRCA2 to 1, when we compare BRCA2 to the wild type, but not really when we compare BRCA1 to the wild type, demonstrating that these are unique differences in BRCA2. So we then take, yeah, go ahead. Say that again.
Are those pathways upregulated or downregulated?
So we're gonna go deeper and really distinguish the direction. Oh, no. Oh, sorry. Okay. So now we have all of those pieces, and we try to sort of take those pieces almost as a puzzle. And knowing what we know in the literature and previous studies, we tried to put it together in a hypothesis. And what we then hypothesize is that BRCA2 mutation would induce this vulnerability that would affect the Wnt signaling pathway, which, as we know, also affect oxidative phosphorylation. And we are going to try to link this to response to either chemotherapy or PARP inhibitor, because that's something that we know that these pathways regulate. We also hypothesize that this vulnerability affects the tumor immune microenvironment, which may or may not be directed by Wnt signaling, leading to improved survival. So it's a lot of different pieces. For the purposes of this talk, I will be focusing on the validation of the Wnt signaling pathway, but we have a poster out showing the initial validation for the immune regulation. So going now to Matt's question, especially for the Wnt signaling, how is it regulated? Is it going up? Is it going down? So before we go deeper into the different genes, let's briefly talk about the canonical or the classical Wnt pathway. So what is known about this pathway is that when there is no ligand, beta-catenin is phosphorylated by the beta-catenin destruction complex, leading to its ubiquitination and degradation. However, in the presence of the Wnt ligand, there is the structural event that happens in the membrane that sequesters the beta-catenin destruction complex, leaving beta-catenin free, which then goes to the nucleus. In the nucleus, it binds to TCF7, it kicks out Groucho. This is an inhibitory signal, binds to TCF, which is the transcription factor, and activates Wnt target genes by binding to the Wnt response elements. And what we know about this pathway is this regulates development. And for the processes related to cancer, it regulates stemness, chemoresistance, metastasis, as well as affect immune regulation. So as we said, Wnt pathway is one of the pathways that's differentially regulated between BRCA2 and 1, BRCA2 and the wild type, but not BRCA1 and the wild type. And so we look closely at the genes that's in this pathway. There's about 15 of them that's differentially expressed. And what you can see is there is, out of the 15, you can see upregulation in BRCA2 of genes that are known to inhibit the Wnt pathway. And you see the same genes being upregulated in BRCA2 mutant tumors if you compare it with the wild type. So if you put that in a pathway using iPathway Guide and the perturbation function, what you can see is all of the genes that are upregulated in BRCA2 are inhibiting at the level of the receptor. And if you follow the pathway looking at perturbations, these pathway analyses show that beta-catenin is then predicted to be downregulated in the BRCA2 mutant tumors. So we now have the hypothesis that the BRCA2 mutant ovarian tumors are less responsive to Wnt signaling because most of the inhibitors are on the membrane. So to start validating this, we utilized isogenic mouse ovarian cancer cell lines. We used the cell lines that was developed by Dr. Ian McNish. So they used the ID8 mouse ovarian cancer cell line, which are derived from mouse epithelial ovarian cancer cells and made malignant by serial passaging in vitro. Dr. McNish's group CRISPR'd out P53 in this model so that it reflects the high-grade serous ovarian cancer histotype. And from the P53 CRISPR'd cell lines, they also CRISPR'd BRCA1 and BRCA2. So for the succeeding slides, we are going to focus in comparing these cells. Just for simplicity, sometimes I would refer to these cells as just P53, these cells as BRCA1, and these cells as BRCA2. So the first thing that we ask is, do these isogenic cells recapitulate the transcriptomic difference observed in patients? And the answer is yes, they do. So we validated 3 Wnt inhibitors, DKK1, Notomaxin-2, and see that they are significantly upregulated in the BRCA2 cell line. We validated AXIN2 by Western blot and show that it is really upregulated in the BRCA2 mutant cell line. So with that, then we ask if these isogenic cells respond differently to Wnt3A treatment. And we did that in 3 levels. So the first level is at the receptor. The second level would be the stabilization and location of beta-catenin. And finally, we looked at gene targets. So first, at the level of the receptor, we looked at the phosphorylation of LRP6. So we took the cells, we treated them with 100 nanograms of Wnt3A, and that's the dose that we used all throughout. For determining the activation of the receptor, we did a time course of half an hour, 1 hour, 4 hours. And you can see here with the results for P53, there is an upregulation and activation of the receptor. BRCA1, there's also an activation of the receptor. And in BRCA2, surprisingly, there's still an upregulation of the receptor. If we do the quantification here, you would see that all of them are activated, although with the quantification, you can see that BRCA1, BRCA2 probably have lower in terms of the fold increase from control. But all of the cells demonstrate activation of the receptor upon treatment with Wnt. So then we looked at the second level, which is the stabilization and localization, by looking at the expression and cellular location of beta-catenin. So before we go to the data, I think it's important to review the cellular pools of beta-catenin. So what is known is that newly translated beta-catenin associate with E-cadherin in the ER, and that then goes to the membrane and constitutes the membranal pool of beta-catenin. If E-cadherin is not there or is lower, anything that's extra, it goes in the cytoplasm, which we know can be targeted by the destruction complex. But if there are some signals that prevents the phosphorylation, then you get accumulation of it, and that becomes your cytoplasmic pool of beta-catenin. Stabilized beta-catenin tend to go to the nucleus, as we talked about, to transcribe Wnt targets with TCF, and that's the nuclear pool of beta-catenin. So we did cytoplasmic and nuclear fractionation, and you can see this is a pretty busy slide, so let me just guide you through here. So we are looking at the 3 cell lines, control versus treatment with Wnt, specifically at 8 hours. You can see here the cytoplasmic fraction and here the nuclear fraction. We have beta-catenin, beta-actin as a loading control, and ILF3 and COX4 are really just for showing the integrity of the fractions. So let's slowly go through this then. So upon treatment with Wnt in the P53, you see the cytoplasmic go up a little, but definitely there is much higher increase in the nuclear fraction over here. When you look at BRCA1, you also see that upregulation in the cytoplasm. It's very hard to say that it's going up in the nucleus though, and the initial thought was, okay, is it getting stuck in the cytoplasm? But we can talk about that more later. Definitely in the BRCA2, maybe it's going up a little in the cytoplasm, but there really isn't much increase, at least at this time point in the nucleus. So with that, we then go to immunofluorescence and really see if we see the same thing. So for the immunofluorescence, we did it for the exact same time point, which is 8 hours. The green here is the beta-catenin immunofluorescence, and the blue is DAPI. So you can see again, P53, a really nice increase in the nuclear fraction. So it's really the classical response. BRCA1 here, you can see punctate staining in the control, and then it's so hard to see if the nucleus is going up because the cytoplasm is just lighting up. And again, it's like, okay, is it getting stuck in the cytoplasm? In the BRCA2, it's very interesting because now you can see that it has the membranal pool that you can see here, which you cannot see in the other cell lines. In addition to that, there is also not much increase in the amount of beta-catenin fluorescence, but something that definitely is very obvious is that at baseline, it's already high. And we see that in the immune fluorescence. We also saw that in the Western blots. So with that, we said, okay, before we do a conclusion, let's see the gene targets, because that's really the end point of it. So for the gene targets, we looked at 4 canonical gene targets: TCF1, cyclin D, c-Myc, and AXIN2. And we chose these genes because they are known to have Wnt response elements. So TCF1, as you know, is the transcription factor that allows beta-catenin to actually transcribe the Wnt response genes. Cyclin D1 is a protein that regulates the progression of cell cycle. c-Myc also regulates the progression of cell cycle, but also controls other things like metabolism and mitochondrial activity. And AXIN2 is part of the beta-catenin destruction complex, and most of the time is considered to be a negative regulator of the beta-catenin pathway. So first, looking at TCF, you are looking at P53, BRCA1, BRCA2, this time looking at a 24-hour Wnt treatment. Before we start to look at all of these bands, I think it's important to talk about TCF. So there are several isoforms of TCF17. Some of them are splice variants, some of them are due to the use of alternate promoters. The first promoter starts with a full length or makes a full length TCF that has a beta-catenin binding domain, where the second promoter then makes a shorter version that lacks the beta-catenin binding domain. What is known is in T cells, for example, where this is mostly characterized, resting T cells would have the dominant negative, which is about 26 or 32 kilodalton, but active T cells would have the full length, which is about 42 or sometimes 48. And so looking here, what we can see is if you look at the full length, very clearly you see upregulation in the P53, not really much in the BRCA1, which kind of makes sense if beta-catenin is getting stuck in the cytoplasm. And the full-length TCF, there's no increase in BRCA2 in response to Wnt, but again, it's already very high to begin with. And in addition to that, you're seeing these lower bands that are representative of the dominant negative TCF. So looking at the other genes, c-Myc, for example, you see upregulation in P53. So again, very classical canonical response in P53, not much movement in BRCA1, nor BRCA2, but again, BRCA2 and BRCA1 looking like higher levels at baseline for c-Myc. We really didn't see much change in cyclin T1. But this is very interesting because now you're finally seeing a response in BRCA2, but it's a response of a negative regulator, which you can see here, upregulation of AXIN2 in response to Wnt. So in summary, BRCA1/2 wild type ID8 mouse ovarian cancer cells activate the classical canonical Wnt signaling in Wnt3A in response to Wnt3A. BRCA1 mutant cancer cells upregulate beta-catenin, but do not really upregulate the canonical gene targets. And BRCA2 mutant ID8 mouse ovarian cancer cells have already higher basal levels of beta-catenin, higher basal levels of the full-length TCF and c-MYC, but the response to Wnt is an upregulation of the negative regulator. So we now then have all of those answered to the first set of questions, which leads us to more questions as usual. So the question is, what is the Wnt response in BRCA1? And is Wnt signaling constitutively on in BRCA2? Because then that doesn't make sense in terms of what we see with the survival. So sub-questions in this constitutive activation is what would be the mechanisms that promote the increase in basal beta-catenin? What would be the mechanisms that direct the specific response to being the negative regulator? And what's the clinical implication of that? So going to the question about what's happening in BRCA1, one of the things that we saw in the differentially expressed genes is that if you compare BRCA2 to 1, we see downregulation of Frizzled-6, which means that Frizzled-6 is upregulated in BRCA1. So we talked about the canonical Wnt signaling pathway. That means there's a non-canonical, right? So that's what that means. So the non-canonical pathway goes like this. When Wnt ligand binds to the receptor, the structure in the membrane is now being led by Frizzled-6. And this conformation, instead of activating or inactivating the destruction complex, it activates kinases like PKC junk or the Rho kinases. And that results in cytoskeletal remodeling, most prominently actin polymerization. So actin polymerization is something that we can assay for using phalloidin immunofluorescence. This is a picture in one of the data sheets where you can see actin polymerization when you see these like lines or filaments. And so we did that. And so here you're looking at control versus Wnt treatment on the BRCA1, and you can see increase in these filaments. You are seeing phalloidin here, which is the actin polymer in green, and DAPI is blue. And these filaments, you cannot see them in P53 or BRCA2. So it demonstrates that Wnt3A activates the non-canonical signaling in BRCA1 mutant ovarian cancer cells. We also then look at the differentially regulated processes that is unique to BRCA1, and we saw a lot that's related to microtubule or filament polymerization. So then we now go to the question, what are the mechanisms that promote basal beta-catenin levels in BRCA2 mutant cells? So we looked at Wnt, it's not different. We look at beta-catenin mRNA, it's not different. And so we then asked the question, is its stability? So we then did a cyclohexamide chase where we treated the cell lines with cyclohexamide 2 hours, 4 hours, 6 hours. And what you can see here is a decrease in beta-catenin levels once you inhibit translation, when you add cyclohexamide, but really much more stable in the BRCA1 and even more stable in the BRCA2. And you can see the quantification here. So we know that beta-catenin is degraded if it's ubiquitinated and phosphorylated. So we figured, okay, then I guess beta-catenin is not phosphorylated in BRCA2. So we went on to look at that, but we know that if we just take the cells, because beta-catenin is degraded in P53, then we're not going to start with the same amount of beta-catenin. So to look at the phosphorylation, we then treated with MG132, we know that now we have the same levels of total beta-catenin. And indeed, when we did that, we see that in BRCA2, beta-catenin is not phosphorylated at all. So we see lower levels phosphorylated beta-catenin in BRCA2 mutant ovarian cancer cells. So one of the ways that beta-catenin can not be phosphorylated is when something is happening in the destruction complex. And one of this is the phosphorylation of GSK3 beta. And so when we looked, it's very obvious that in BRCA2 mutant ovarian cancer cells, GSK3 beta is phosphorylated, which means it's inhibited, and therefore beta-catenin is not phosphorylated. So finally, we go to this question that is still, we're still doing a lot of experiments and doing mechanistic studies. But to answer the question, is the Wnt signaling really on? What's the mechanism that direct the specific response to it being transcription of negative regulators? I think we can piece together all the data and sort of come up with a model of what's happening in BRCA2. So in BRCA2, we know that GSK3 beta is phosphorylated, leading to beta-catenin not phosphorylated and stable. So what we know is that if beta-catenin is stable, it goes in the nucleus, it transcribes Wnt target. But we have to think about that this is happening chronically. And so you get these high levels of beta-catenin, especially in a tumor microenvironment that highly likely would have the ligand. So you really have this progression of high levels of beta-catenin. So what we know with beta-catenin, it has a lot of binding partners. And with proteins and binding partners, it has their preferential binding partners. But once you get a lot of it, it now starts binding to the other proteins that it doesn't usually prefer. And we think that one of these would be the other transcription factors that now leads it to other targets. And these targets, we think, are the negative regulators, like AXIN2 that we see in the cell lines, and the other negative regulators that we see in the patients. So finally, we reach the conclusion that BRCA1 wild type activates the canonical Wnt signaling. BRCA1 activates the non-canonical Wnt signaling in response to Wnt. BRCA2 have saturated beta-catenin signaling that eventually signals to negative feedback regulators once you start pushing into that pathway. I don't know what my time is, but I think I'm good. Just very quickly, Radhika said, that's not enough for me. So she then started a collaboration with Caris. They identified 677 BRCA1, 439 BRCA2, 7,000 HRP. And indeed, with the initial analysis, we see that if you compare BRCA2 with Wnt signaling is coming up significantly in terms of differential regulation. So we have all of these future goals that we can talk about later, but I think really is the finding that GSK3 beta is inhibited, kind of like opens this whole thing about, what is really the vulnerability in BRCA2 mutant tumors. So this is the team. Science is a team sports, the only sports that I play. So majority of the data that I've shown are from Hussein Chehad. Dr. Hussein Chehad recently graduated. Sandra Garofalo also contributed to the data. Radhika Gogoi, our gynecologist collaborator, and of course, Dr. Moore, the director of the Mott Center, but also an amazing mentor. And I want to thank the Janet Burroughs Memorial Foundation for funding support. Thank you very much.
We have a couple of
maybe right
here
for Doug.
Yeah, so do Wnt inhibitors work in clinical trials?
No. And I think, the answer to that is the Wnt inhibitors that we have are really acting upstream. There's also a question about the pharmacokinetics, pharmacodynamics, and really right now it's sort of, we know that the beta-catenin pathway does this, we do not know how it fine-tuned. So I think that's the next step where the inhibitors would go, is it really trying to find the fine-tuning that happens on the distal end of the pathway instead of the upstream of the pathway.
That they've been tried in both BRCA1 and BRCA2 in ovarian cancer.
Clinically, I'm not sure. Maybe the clinicians can answer that for me, but I know that there are mouse models that they have shown that it can synergize.
I think there was a clinical trial out of Alabama, but I don't think it was very positive. I don't remember exactly the details.
Thank you.
Yes, yes.
Very beautiful work. I think everybody knows that these BRCA patients tend to do better than BRCA1, and they're also better responders to PARP inhibitors. And this is a kind of a lingering question in the field, why BRCA patients so much better than most people work on BRCA1. So one criticism that you might get is that, you know, this is a murine cell line.
Right.
Have you looked at the human cell, you know, human cells?
Starting to. Yeah.
Question. So when you ask the average like clinician about BRCA1 versus 2, really what would come up is the, you know, in the germline population, you know, as we know, BRCA1 is almost twice as likely to develop ovarian cancer, and also on average presents about 5 years earlier. So I think the canonical, non-canonical data you have is really interesting. I just wonder if there's any thought or like hypothesis generating insights you might be able to get out of the non-canonical BRCA1 in terms of like the pathogenesis, right? So if we think germline is twice as likely to develop and it shows up earlier, I know we're thinking about, you know, developmental therapeutics, but if there's like a carcinogenesis angle to this too.
Yeah. So the good thing with the non-canonical is it's a little bit more specific relatively compared to the canonical, and there's a lot of the metastasis aspect of that. So whether or not that plays a role, at this point we don't have the data, but you know, definitely worth looking into. So thank you very much. I am now going to introduce our next speaker. So it is a pleasure to introduce Matt Anderson. Matt is joining us from Tampa. So Matt is a tenured professor in the Department of Obstetrics and Gynecology in University of South Florida. He is a medical director in the Office of Clinical Research and associate director for shared resources at Tampa General Hospital Cancer Institute. Matt has a successful and busy clinical practice and played a key role in expanding the ovarian cancer program at Tampa General. He is a clinician, educator, scientist. He leads an active research lab supported by NCI, NSF, and various foundations. Welcome, Matt.
It's your presentation is not open yet. Can you take care of this? Can you put a full screen and a full presentation and get it?
How about that? All right. So thank you, everyone. I'd like to thank Dr. Moore and Aisha for the invitation to speak, as well as to thank the sponsors, Mass Mutual and Mioka, for sponsoring this symposium. There are actually a fair number of opportunities to speak about ovarian cancer, but it's always fun to come and speak among friends. I've known a lot of people in the room here for multiple years. And so it's always exciting to come and be able to talk about what we're up to. A couple years back, I relocated from Baylor to Tampa General, and one of the questions always is, well, why did you do that? And I think really the opportunity, or why I was interested in doing that, was because Tom Rutherford had been busy building, after he left Yale and moved to Tampa, a program for the use of heated intraperitoneal chemotherapy for the treatment of ovarian cancer. That's something I became very interested in, and the opportunity to build out a program that not only examines questions related to HIPEC from a clinical perspective, but also a translational perspective, was something that I thought was very exciting. And so today, what I'd like to do, a little bit different from Aisha's talk, what I'd like to do is talk about some of the rationale for of why HIPEC, talk about some data about its potential utility, and then also talk a little bit about what we're setting up in terms of a program to understand and optimize the use of this strategy for the treatment of ovarian cancer. And then if we have time, try to relate this back to a series of clinical trials that examine the utility of intraperitoneal chemotherapy as a strategy for treating ovarian cancer, which has been a little bit on the controversial side. So having said that, I just start off with a little bit of a case. This is actually a woman who presented to Tampa General, 54 years old, who had presented with abdominal swelling, nausea, ends up getting in the emergency center, gets a CT scan, 8-centimeter complex adnexal mass, ascites, and some other findings worrisome for peritoneal carcinomatosis. Her CA-125 level was 656, so definitely elevated. We end up, make a long story short, we end up taking her back to the operating room for a diagnostic laparoscopy to obtain biopsies to establish a diagnosis, as well as assess her suitability for primary clinical debulking. And this is what we see here: diffuse peritoneal metastases. Oops, you know, that was a touchscreen. Surprise. And under the microscope, this is what we see under high power view, the kind of typical histologic picture of a high-grade serous carcinoma. For many of the clinicians in the room, you'll recognize, and even many of the researchers, that, as Alicia pointed out just a few minutes ago, outcomes for ovarian cancer until recently have probably changed very little over the past several decades. And primary therapy for this woman and many others consists essentially of some combination of surgical debulking with 6 cycles of platinum-based chemotherapy. And using a combination of surgery plus chemotherapy, as a gynecologic oncologist, we are able to put more than 80% of women into a complete clinical remission. So this is a very different scenario than, say, many other metastatic solid tumors, which respond poorly to chemotherapy and ultimately progress with little opportunity for remission. However, in ovarian cancer patients, that disease, depending on the extent of debulking, response to treatment, the genetic makeup of tumors, the median disease-free interval for these patients ranges somewhere between 18 to 33 months based on a number of different factors. The interesting thing about ovarian cancer, and part of what attracted me to work as a gynecologic oncologist, is that in contrast to nearly all of their solid organ tumors or cancers, ovarian cancer essentially remains confined to the peritoneal cavity. And so to me, at the time when I was a medical student at Yale, going and thinking about what I do with myself, to me, this seemed to be an ideal opportunity to develop focused intraperitoneal therapies that could be used to target this disease. Now, interestingly enough, ultimately, despite the fact that we have good strategies to put 80% of people into a clinical remission, more than 80% of these patients will ultimately have a recurrence of their disease. And almost uniformly, there's this thought to be due to the fact that small microscopic metastases persist within the peritoneal cavity that I, as a surgeon, cannot identify visually, that we cannot detect otherwise by molecular strategies. Yes, you could say, well, there's always this possibility of circulating tumor DNA in the serum, which may or may not be relevant. There's some issues related to that, but that's definitely an emerging area. But at the end of the day, when I'm in the operating room, there is no way for me to identify where all the sites of these tumors may actually be, despite the fact that 80% of the time at our institution, we can debulk disease down to a microscopic level. That is, I can see no gross evidence of disease left within the patient. Despite the fact that they have good clinical response and an optimal surgical outcome, we know that 80% of those patients are going to come back, their disease is going to come back for 80% of those patients. So what is our interest in heated intraperitoneal chemotherapy? So both Tom and I are very interested in this concept because this gives us a potential strategy, different than traditional cytotoxic chemotherapy, to try to target those small microscopic implants of disease. The technique itself was pioneered by a surgeon named Dr. Paul Sugarbaker more than 50 years ago. Dr. Sugarbaker worked for many years in DC, recently just retired, but he developed this as a technique to target other types of intraperitoneal chemotherapies that, similar to ovarian cancer, typically remain confined to the peritoneal cavity. Things like mesothelioma, low-grade appendiceal carcinomas, he, over 50 years, developed more than 500 publications, developed a strategy whereby you are able to infuse heated solutions of chemotherapy into the peritoneal cavity with the goal of chasing after these types of microscopic implants. And initially was conceived as a possibility for even treating macroscopic disease. So having said that, why do this? Well, initially it was started as a strategy to control malignant ascites, but then clinicians quickly realized that actually certain drugs such as cisplatin or paclitaxel are cleared only gradually from within the peritoneal cavity. As a gynecologic oncologist, I can tell you that from my perspective, understanding the biology of the peritoneal cavity is a relatively underexplored topic or concept in human biology. But there is a biology. So for example, there's a directionality to the flow of ascites within the peritoneal cavity, which explains why ovarian cancer metastases are more likely to end up on the inferior surface of the right hemidiaphragm. How is that generated? Is it just gravity, like, the difference between North and South America, which way water circles down the drain? Okay, kind of doubtful given the fact that we're up and walking around. And then what governs the production, maintenance of the immune microenvironment within the peritoneal cavity? There's research in this area, but it's not overwhelming, and at baseline is not necessarily something that we understand. It's an intriguing concept because, for example, I recently, several years ago now, reviewed an Israeli paper that suggested that patients who are BRCA1 mutated are much more likely to carry a germline mutation in BRCA1, are much more likely to experience problems with acute appendicitis. Okay, it suggests that there are issues fundamentally, which now we understand a little bit better, about between BRCA, immune defense, and inflammatory responses within the body. Interestingly enough, you can place certain drugs such as cisplatin. It is relatively easy to accomplish a 30-fold higher concentration of cisplatin within the peritoneal cavity than what is found in the circulation, and more than 1,000-fold higher concentration of paclitaxel within the peritoneal cavity than what you can accomplish through an IV route. And that's really a fundamental principle behind the whole concept, not just of HIPEC, but also intraperitoneal chemotherapy. And for the clinicians in the room, you're probably immediately thinking about Joan Walker and these series of IV trials, which we'll hopefully have some time to discuss at the end of my talk. So why would we want to contain this? This seems like a great strategy just by itself, delivering drugs or treatments within the peritoneal cavity. Why would we want to combine this with hyperthermia? Well, first of all, there's some really good data to suggest that malignant cells can be selectively destroyed by hyperthermia, even relatively mild hyperthermia, somewhere between 41 and 43 degrees Celsius. Temperatures which can be tolerated intraoperatively with patients with the correct clinical management. In most cancers, that microcirculation exhibits a decrease in blood flow or even complete stasis in response to hyperthermia. I find this question particularly interesting. Kunle Adunsi at the University of Chicago recently visited our institution, and using very mouse models can show in implants of ovarian cancer, and also extending that work into Omentum, half the metastases of ovarian cancers, a large proportion of these metastases, the microcirculation may actually not even be functional. Okay, which raises a whole series of other questions about how are we impacting the regional blood flow or the local blood flow of these tumors. There's some data to suggest that hyperthermia can be used to favorably impact that blood flow to the clinical benefit of patients. And there's also good data to show that hyperthermia results in a locally acidic microenvironment that resulting from changes in metabolism, the accumulation of lactic acid, that preferentially accelerates death for more fragile malignant cells when they're actually exposed to hyperthermia. And so there actually is good rationale to suggest that this is an advantage worth talking about. Other advantages of the use of a heated intraperitoneal chemotherapy include the fact that it's been shown to improve the absorption of drug and the susceptibility of cancer cells to drugs when incubated with different agents. It also, again, gives us the strategy to leverage that ability to concentrate chemotherapy within the peritoneal cavity, and at the same time, minimizing extraperitoneal exposure to chemotherapy and resultant side effects. I think one of the big differences that I experienced after leaving my fellowship at MD Anderson and actually serving part-time there in faculty for a while, going across the street to Ben Taub, which is a big county hospital in Houston, even now practicing in Tampa, is that women in the real world don't necessarily have time to feel sick as they're getting treated with chemotherapy. Oftentimes, my patients have real world concerns, getting back and forth to the hospital, who's taking care of their family, be able to work a job and support themselves, many other real world issues, okay? And not infrequently, particularly now since I've moved to Florida, there are many patients who simply won't tolerate a lot of side effects with chemotherapy. And so this gives us an ideal strategy to potentially treat patients with high doses of chemotherapy, potentially with clinical benefit, in a way that minimizes many of those side effects, and at the same time, potentially minimizes some of the adverse effects that were observed with the IVIP combination treatment trials led by Joan Walker through the GOG, where as many as 60% of the patients enrolled in those trial experimental arm were unable to finish the complete treatment due to the intensity of side effects. And we'll hopefully have a little time to get into that towards the end. But this is a big benefit because, again, this is a treatment that is administered while the patient is asleep in the operating room, and therefore, hopefully, practical side effects are minimized. This is actually a schematic for how we performed HIPEC. This is not us in Tampa General. This is actually from a hospital in Europe. And if you look here, it's a closed circuit. We actually insert 2 catheters. There's actually a pump very not similar to what you would see for cardiac bypass, where it takes a reservoir of fluid, runs that through a heater, and then actually pushes that into the peritoneal cavity. We actually do a couple things intraoperatively. We remove the falciform ligament. We get rid of all the possible adhesions we possibly can, with the goal of sort of enhancing that circulation within the peritoneal cavity. And then we have an outflow port at the bottom. Okay, and in our system, we actually inject a pure as it's coming into the patient, and then we monitor both the influx and outflux temperatures, as well as the patient's core temperature, monitor urine output, and do a number of things that we think actually are very helpful in terms of minimizing potential side effects. If you look in the literature, there's a fair amount of data that would suggest that this procedure can be dangerous because our goal is to elevate that patient's intraperitoneal temperature to somewhere between 41.5 and 42.5 degrees Celsius for 90 minutes, okay, while we administer chemotherapy, okay, keeping the core temperature generally less than 39 degrees Celsius, okay? And so there's a number of different tricks that we've worked out to kind of control that. You always have to worry about the fact that the seal between the diaphragm separating your peritoneal cavity from your lungs is never perfect, okay? So it's possible for some of this fluid to leak across the diaphragm into the pleural spaces, for example, okay? But again, there are ways to manage this as well. At the conclusion of that 90 minutes, we're able to break the circuit, drain the chemotherapy, wash the patient's belly out, okay, and then finish the surgery. In general, the goal for us is to debulk that patient down to microscopic disease before the patient undergoes the procedure. Well, there are some tricks to this because what you don't want to do is necessarily have to do a bowel resection, put that back together before the HIPEC, because the metal, particularly if you're using a metal staple line, because that will heat up the metal staples and actually locally injure the bowel. Okay, and so, for example, we'll staple resect bowel, do the HIPEC, and then after the HIPEC, come back to do a reanastomosis, not infrequently hand sewn, with the goal of avoiding a direct compression from the type of surgical staples used to do a bowel resection. So, having said that, okay.
Sorry, what is the temperature again?
We try to get about 41.5.
41.5.
Somewhere between 41.5 to 42.5 within the peritoneal cavity.
Within the patient, okay. Including with the chemotherapy.
Including, and right, so we'll give the chemotherapy, once we hit 41.5, we get 2/3 the dose of chemotherapy, 45 minutes, we get the last 1/3, and then continue for 90 minutes, monitor core temperature. Patient will be like on a cooling blanket, for example, to kind of help control the core temperature. We have a temperature probe in the patient's mediastinum and their esophagus to manage core temperature. We also get our goal is to have them making 200 to 300 milliliters of urine an hour. Okay, so they'll get fluid boluses, Lasix. That's very important because your kidneys are very close to the peritoneal cavity. One of the potential adverse side effects of this is actually renal injury. We found that we can control that by flushing a lot of fluid at room temperature through the patient. Okay, helps keep their core temperature manageable, also helps to protect their kidneys. And so we want these patients definitely making large volumes of urine. Then if I sort of back for the clinicians in the room, one of the caveats of this is not necessarily a procedure for patients who have very fragile heart failure, okay, because they're not necessarily going to tolerate all that fluid, for example, okay? And this absolutely is a physiologic stress. When you open that patient's belly back up, it's almost like that patient has a little mild sunburn on the inside. Everything's sort of like a little bit of edematous, okay, and you can tell that they've been exposed to something different than the typical surgical procedure.
So, Matt, any concern of adhesions or fibrosis when you flush the kidney, induced injury?
No, we've not had, I will tell you that we've done close to about 109, almost 200 of these procedures. We've had 0 incidents of renal injury.
Or adhesions?
Well, that's an interesting question, okay, because there are patients we've had to come back and reoperate on, and the pattern of adhesions. So, any patient you're having a big debulking surgery on, okay, is prone for adhesions, right? Okay, the pattern of adhesions in these patients is very different, okay, than what you would observe actually after a typical debulking procedure, for example. Okay, they tend to be much more diffuse, actually, and almost sort of like glassy. It creates a very different type of adhesion for the limited number of patients we've had to reoperate on it, actually. So it does have an impact on, I think that's not definitive proof, but it certainly is suggestive that we're impacting the sort of immune response involved in adhesion formation.
Because of the flow rate?
I don't think it has so much to do with the flow rate, because the flow rate's essentially always fixed, actually. But you're walking a fine line between an adequate flow rate to maintain the temperature versus not too fast, the temperature goes too high, too slow, temperature drops too low at the exit port, right? So you're adjusting the temperature, you're sort of monitoring the patient very closely, repeated serial blood gases, oxygenation levels, lactate levels intraoperatively. You have to walk a very fine line between the temperature at the inflow port, the outflow port, and the difference is governed by the flow rate as well as the temperature coming in. You can't go too high because you risk injuring upper abdominal organs, where that's where we put our entry port. Okay, and so you're sort of walking a fine line.
So you said you did 200 of these. What stage of ovarian cancer? Really,
most ovarian cancers are stage 3 and 4. Actually, okay, so now there's a number of different, most ovarian cancers, when they, probably 90+% of ovarian cancers that we see coming in are going to be stage 3 or stage 4 disease, right?
Have you tried at earlier stages though?
Yes, we have actually, and we'll get a little bit of that towards the end. Okay, I'm not talking about so much of the data today as so much as the program and what we're trying to accomplish. But we have, and not all ovarian cancers are created equivalently, right? Okay, and so the question immediately becomes, well, does this potentially work better for like high-grade serous or, for example, low-grade ovarian cancers? And I'll toss out a little bit of data to hopefully kind of spur some thought about this. The biggest question is always, does this actually help? Okay, and so there actually has been at least one solid prospective randomized clinical trial that has examined HIPEC under conditions where we think that is actually most likely to work, that showed distinct benefit. This was actually run by a Dutch group that enrolled a little over 260 patients who have been debulked to microscopic disease or less than 1 centimeter. The vast majority of these patients have been debulked to microscopic disease. And when you look at outcomes for those patients, HIPEC was associated with a measurable and statistically significant improvement, not only in the duration of the progression-free survival, but also overall survival for these patients. There's been at least one other second prospective trial of HIPEC from a group in South America that similarly suggested a clinical benefit, okay? And then there's been multiple papers that suggest there's no benefit, although again, you have to take all this with a bit of a grain of salt because people have used this procedure under a number of different circumstances where it may or may not actually work, okay? And what those conditions actually are not completely clear. I think one of the themes that becomes very quickly clear is that this is a procedure to chase after microscopic disease. The vast majority, all of the clinical trials with negative findings, including a study from Memorial Sloan Kettering, several others, that have enrolled patients with bulky disease have failed to show improved impact, okay, or improved benefit, improvement in survival, probably because the HIPEC is, that heated temperature is unable to penetrate the full thickness of a bulky metastasis, right? And that's sort of one of the themes that kind of comes out, and we can talk a little bit more about why I think that's an important part of this, okay? But there is good prospective randomized clinical trial, at least one, okay, that has clearly established a benefit. Now, this trial was criticized widely, okay, here in the United States for a number of reasons. Things like, well, protocol enrollment was slow. Okay, well, true. Okay, although the patients were all uniformly treated, they were concerned that there might be more low-grade or non-serous cancers enrolled in this patient. Okay, but the total number of patients was like 5. Okay, out of the 263 had a cancer that was not a high-grade serous carcinoma. So I really don't consider that to be a valid criticism. But in general, this has led to a lot of discussion and controversy from a clinical perspective in the field, with people sort of coming down sort of with strong opinions on either side. But what it has provoked are multiple clinical trials, okay, with the goal of better evaluating the efficacy of this procedure as it stands with the use of intravenous or intraperitoneal cisplatin or carboplatin chemotherapy. These are and there's probably the first of these will be actually available for data. Sorry. So is the OV-HIPEC-2, which is being run by a Dutch PI through a European consortium. There's another patient here, a CHIPPY study, which is going to randomize 1-to-1 a phase 3 randomized phase 3 prospective trial to enroll 432 patients with newly diagnosed epithelial ovarian cancer, and primary or interval reduction is allowed. Primary endpoint is going to be disease-free survival. HINOVA, which is actually an Australian study, which is going to use HIPEC versus an alternate strategy for stage 3 epithelial ovarian cancer following 3 to 4 cycles of neoadjuvant chemo. And importantly, it's only going to enroll patients for whom a debulking surgery has resulted in minimal residual disease. And then there's a Chinese study as well, looking only at the role of HIPEC, okay, for treating platinum-sensitive recurrent epithelial ovarian cancers with mutation with HR deficiency, homologous recombination deficiency. And so I think we're all anxiously waiting the outcomes of these trials. There's also an ongoing effort to do something to evaluate the use of a clinical strategy known as PIPEC, or pressurized intraperitoneal chemotherapy, where you're using laparoscopic ports. Increasingly, about 20–25% of all ovarian cancer debulkings these days are done laparoscopically, robotically. Okay, it's a long and complex procedure, 8, 9, 10 hours. Okay, that's controversial. Okay, there's some preliminary data suggests that's feasible, but interestingly enough, okay, there actually is a study based at City of Hope in California looking at PIPEC or this pressurized. You can actually use the laparoscopic ports to apply pressure plus heat in a closed abdomen using laparoscopy, with the hypothesis being that the pressure will help to force chemotherapy further into the metastasis, okay? And this trial in particular enrolled patients with bulky disease, okay? And I can tell you, just because I know people in the trial, this is, there's some interesting elements about this. Okay, there actually have been some meta-analyses. There's a number of studies that have done and looked at this strategy in Europe. Okay, and it does actually have a fair number of adverse events associated with it. 12 to 15% of patients who have undergone this procedure and other types of clinical trials in Europe have had some type of adverse side effect, such as bowel obstruction, bleeding, or abdominal pain, and reportedly does not have a negative impact of life, but negative impact on the quality of life. It's unclear whether there's actually going to achieve or it's an experimental objective of improving survival. Okay. But, again, objective response rates in the limited studies that have been done would suggest that there's like a response to HIPEC with a median survival of 11 to 14 months. Again, not impressive necessarily, but hopefully we'll have some further answers. Again, I personally it's unclear to me whether or not this clinical trial is being conducted under circumstances that will achieve optimal outcomes. So, and the reason why I say this is because this procedure really has not been optimized for the 21st century treatment of ovarian cancer, right? So these trials are being conducted under circumstances where we've not really taken the time to understand the molecular composition of the tumor, its potential response to chemotherapy, factors that, as Aisha pointed, some of the data that we know help to determine not only responses to chemotherapy, but overall survival for a number of reasons that we may or may not understand. And so, as an example of this, I just I just want to share a retrospective study that was done by an Italian group where they took 70 patients with stage 3 to 4 ovarian cancer who were both BRCA wild type or either BRCA1 or BRCA2 mutated. 63 of these 70 patients underwent cytoreductive surgery. They all received neoadjuvant chemotherapy. 63 of the 70 patients underwent cytoreductive surgery to microscopic disease. The remaining 7 patients have been debulked down to a minimal residual disease no greater than 2.5 millimeters. There was one of the concerns with this study is, from my perspective, is that the vast majority of patients actually received bevacizumab. And there's some data from IVIP clinical trials that would suggest that bevacizumab actually may be counterproductive under circumstances where you're trying to actually treat ovarian cancer patients using an intraperitoneal strategy. Well, again, if time permits, we'll try to get into a little bit of that, okay? And the vast majority of these patients, 27 to 30, were BRCA1 mutated. And what these investigators found, looking at both progression-free survival and overall survival, is that as anticipated, patients who have a BRCA wild-type tumor fare the worst in terms of progression-free survival. Patients who are BRCA mutated, okay, but do not undergo HIPEC, seemingly do the best. And these two blue lines, the teal and the lavender here, are BRCA mutated, BRCA wild type who underwent HIPEC, and BRCA mutated who underwent HIPEC. And these three groups are not statistically different in terms of their survival or their overall difference. And again, similar benefits in this study, a limited number of patients, but the patients who were BRCA mutated who do not undergo HIPEC, the patients who are BRCA mutated who underwent HIPEC, and patients who are BRCA wild type or underwent HIPEC all had similar outcomes in terms of progression-free survival and overall survival, and all three groups did better than patients who are BRCA wild type who did not receive HIPEC. And these investigators concluded, interestingly enough, that HIPEC may actually serve to eliminate the disparity, okay, in terms of survival benefit that is conferred by having homologous recombination deficiency. That's interesting because in animal models, okay, there is data from at least one paper that shows that the administration of HIPEC to a mouse model selectively downregulates BRCA2, which opens the door to ask whether or not we can use HIPEC as a strategy to sensitize ovarian cancers to the administration of a PARP inhibitor. Okay, completely unclear, has never been tested in human tissues before. Okay, but it's a valid question. The second question, and the other thing I would like to talk about is that to address kind of the naysayers about who may not believe this, is some of our work we've done on our own using the NCDB database. So if you look at the database, as a result of these trials and the ongoing efforts, there is an accelerating interest in HIPEC among gynecologic oncologists in the United States. And to date, if you look in the NCDB database, okay, there have been a total of 652 women treated with HIPEC for whom we have clinical data across 253 COC certified hospitals in the United States. And so what we want to know is how these we actually asked this, actually hopefully submitting the manuscript on this next week, but we want to know how these women did compared to people who did not undergo HIPEC. And so we used propensity scoring to identify a cohort of 652 women with ovarian cancer, stage 3, okay, who underwent debulking surgery to microscopic disease, okay, or less than 1 centimeter, and who are matched in terms of not only age, but stage, Charlson morbidity scoring, as well as whether or not they went primary or interval debulking. Because when you potentially, or how you potentially integrate HIPEC into the care plan, our hypothesis could potentially make a difference. Interestingly enough, using this database, okay, we have found that median overall survival for women who underwent HIPEC with an interval debulking surgery significantly improved median overall survival from 60 months to 70 months in a statistically significant fashion. But a similar benefit was not observed for patients who underwent HIPEC with primary debulking prior to the administration of any type of chemotherapy. Now, there's some serious limitations to this data because there's no data on chemotherapy, and this database is a purely surgical database, but it's certainly intriguing and supports and raises the question, again, which I would put forth, that we don't really understand when or how you might be able to leverage these strategies to actually improve patient outcomes. So, having said this, okay, so where do we go from here? Well, there are the multiple ongoing clinical trials, but again, it's my fundamental hypothesis that we have not optimized this potential strategy to its maximum, and there's plenty of hints of a potential clinical benefit, okay? And so how can we go about doing that? Well, first of all, as I mentioned, we have treated more than 195 women with ovarian cancer over the past 4 years. All of these patients have undergone cytoreductive surgery to microscopic or complete gross resection, okay, because those are the only circumstances under which we'll actually perform a HIPEC for patients because of, again, in light of the data we talked about. They have all been treated with an identical chemotherapy regimen, same doses, same patterns, okay. We have abstracted matched clinical demographics. At the same time, since I moved to Tampa, we've been busy chasing around and collecting specimens of tumor, omentum, peritoneum, ascites, fluid from the abdominal ascites, as well as PBMCs prior to HIPEC, immediately after HIPEC, and then 2 weeks later, okay, with the goal of understanding how this procedure may actually impact the immune responses within the peritoneal cavity. As I mentioned, it's sort of like having a sunburn, and this shows up clinically because if you compare HIPEC treated patients to non-HIPEC treated patients in terms of their recovery, 80% of our debulking patients will go home the next day at Tampa General, okay, because of our ability to use ERAS and a number of other things. That's really kind of reflecting of Tom's efforts and kind of ramping up our HIPEC in an intense fashion, or our ERAS protocols in an intense fashion. The HIPEC will delay return of bowel function by a day or two, and the patients just feel uncomfortable. Right. Okay. I can tell you that we've not had anyone come in and goes, "Oh my God, I'd never do that again. It was awful." Okay. But you know, again, how people do with this and how they feel about this is really unclear. And again, an area of opportunity for exploration. In addition to all those specimens, okay, we also have we have whole exome and whole transcriptome profiling on a matched specimens, okay, from all of these patients, okay, pre-treatment. Okay, and so over the last 6 months, we've now begun to operationalize a protocol to leverage these to address a number of questions. Well, first of all, what is the impact? Just simple clinical questions like, what is the impact of HIPEC on the incidence and severity of specific perioperative outcomes, right? Are we seeing problems with renal failure? Are we seeing problems? Does it alter the pattern of recurrences? There's one small paper that came out of the Cleveland Clinic that would suggest that the use of HIPEC alters the distribution of postoperative metastases, and you're actually maybe more likely to see distant metastases in sites where ovarian cancer doesn't typically show up. Okay, but does this relate to the degree of peritoneal stripping, and how are we altering the peritoneal biology in ways that we could potentially monitor or correct for this? Okay, again, they're still rare, okay, these types of distant metastases, but it is a possibility. Okay, are there specific surgical interventions that we can use to improve outcomes further? Okay, and then what is the actual impact of intraoperative complications on acute outcomes? Like, we have surprisingly low levels of complications compared to what's been reported in the national literature. Okay, but for example, how do you manage pleural effusions? So we're using this data set to start to go after and address some of these questions. And in addition, we're specifically expanding into specific clinical trials. We can use HIPEC, okay, to begin to treat low-grade ovarian cancer. We put together an unrelated, okay, but kind of an interesting concept is using HIPEC. There's one small pilot trial that was examining the utility of HIPEC for managing early stage leiomyosarcoma. Now, I think that's sort of doomed for many reasons because again, that cancer metastasizes vascularly, right, hematogenously, okay, and oftentimes by the time you catch those cancers, they've already probably metastasized. So distant recurrence rates tend to be very high, like 50% for those patients. However, there's a problem with morcellation when patients undergo a laparoscopy. You don't really, most of the time when people identify leiomyosarcoma, it's usually at the time of surgery or afterwards when someone is having a hysterectomy for what they thought was a fibroid, okay? And historically, I don't know if you guys follow this at all, but a number of years back, there was a big brouhaha, okay, because this problem actually happened to the wife of a cardiovascular surgeon at Harvard. She unfortunately ultimately perished from her disease, but in essence, the surgeon was very upset because they felt like they had been misquoted the probability of having a problem of discovering an occult leiomyosarcoma preoperatively. Anyway, to make a long story short, the sort of excitement around that situation, unfortunate situation, led to withdrawal of uterine morcellators, but that procedure is starting to make a comeback among gynecologic oncologists out in the community because it's a whole lot easier to do a laparoscopic hyst, okay, for fibroids than it is to do an open case under circumstances where the goal is really trying to get that patient home the same day. So our question is, can we use HIPEC, okay, as a tool to tackle the intraperitoneal spillage of tumor from an early stage leiomyosarcoma, for example, right? Okay, and because this may be sort of a rescue procedure that we could potentially use for women who've undergone an accidental morcellation of their uterus for an early stage leiomyosarcoma. The second question I want to know is, how can we identify or biomarkers or define subsets of patients from a molecular level, okay, who are most likely to benefit from undergoing this procedure? There is some suggestion, as I mentioned, the Chinese trial that focuses solely on the use of HIPEC to treat HR deficient tumors. There's some data in literature to suggest that HR deficient patients may do better following this procedure. Unclear to the degree to which that's true, but can we, using state-of-the-art technologies for 2023, utilize these whole exomic and transcriptomic profiling, pre-existing patterns of gene expression prior to the patient undergoing HIPEC to identify subsets of patients who are most likely to benefit from undergoing this procedure? And conversely, okay, can we then use this to interpret some and reinterpret outcomes from some of these ongoing prospective trials? And then we wanted to specifically understand the role of some of these specific genomic events in terms of sensitizing ovarian cancers in specific genomic contexts to this treatment, right? Okay, and so we're busy. We've recruited a team to work on this. People from using combination of more traditional strategies, looking at patterns of mutation as well as machine learning to look at structural alterations in DNA. One of the interesting things about HIPEC is that, and heat in general, is that one of the first things that goes up, okay, only one paper, really good paper, looking at the molecular response of ovarian cancers to HIPEC. And one of the first things that goes up are certain types of heat shock proteins, okay? But it's entirely possible that targeting those can be used to improve HIPEC outcomes. Under those circumstances, there's very good data, I think in several studies at MD Anderson, where the tertiary quaternary structure of DNA actually has a determinant on patterns of gene expression and potential outcomes in different types of cancers. And that's something that we're potentially altering occurring, okay, with the use of heat in a way, and it's unclear whether that's a favorable or unfavorable alteration. And these are the types of things we want to start to get into. The next thing we wanted to look at briefly is
to delaying chemo resistance and any benefit of that.
unclear. Never, there are people looking at secondary debulking. I don't think it's ever been really looked at from any really legitimate data to look at whether or not it can be used to reverse platinum resistant disease.
Or delay.
Unlikely that trial would be done simply because it's sort of like a no-go operating on patients with recurrent platinum-resistant ovarian cancer is sort of like one of those board failure maneuvers that ovarian cancer, gynecologic oncologists don't engage in because it's just not been shown to ever have clinical benefit. So, let's see. Where am I? And then lastly, how can we begin to novel therapeutic targets? How can we leverage the heat to actually improve outcomes, locally treat cancers? So, for example, can we use, there's actually an investigator at USF that Gil's been connected with. We're very interested, potentially, once we've identified targets, in pairing this with certain types of iron-based nanoparticles that can be activated to release their target when you run the patient through the MRI, for example. Okay. Now, having said that, okay, how are we doing on time?
I have 2 minutes.
2 minutes. All right. So does the use, okay, and again, this is more of for the clinicians in the crowd, okay, do the pre-existing intraperitoneal chemotherapy trials establish some precedents that can be used to inform these high-tech strategies? And in general, there have been 4 big national trials that have looked at the clinical utility of intraperitoneal chemotherapy. And these kind of occurred sequentially over time. The most recent of this was GOG 272. The most kind of notorious of these are GOG 114 and 172. And just for the sake of time, okay, when you look at a pooled analysis of GOG 114 and 172, you can see that patients who received intraperitoneal chemotherapy under these circumstances did better on an intention to treat analysis, despite the fact that in GOG 174 or 172, almost 60% of the patients were unable to complete the planned IP chemotherapy because of the incidence and severity of side effects. It was sort of a day 1, day 8 dose intensification schedule. Patients were miserable and quit frequently, okay? But despite the fact that more than half the patients in this analysis it was analyzed by intent to treat, never completed the planned treatment, you can still find a benefit for the use of an intraperitoneal dose intensification. And if you break that data down a little bit more, okay, you'll see that IV and IP really begins to benefit patients most under circumstances where you've achieved a microscopic debulking of disease. And I think this really relates to just limitations of how well chemotherapy or an agent in solution in the peritoneal cavity can penetrate a metastasis of ovarian cancer. Now, the kind of fly in the ointment for all this is this GOG 272 study, okay, which actually was read out with negative results, okay, but there are a number. So if in this particular study, this particular study, which randomized patients to looking at comparing IP cisplatin to carboplatin and a number of other changes. This particular study had like 4 to 5 arms. Okay, this particular study failed to show an improvement in survival for intraperitoneal chemotherapy, but there were some very specific differences between GOG 252 and the preceding 114 and 172 clinical trials that I would argue potentially make a difference. First, they reduced the dose of cisplatin from 100 to 75 milligrams per meter squared. They changed the duration of time for the infusion of paclitaxel. It was all outpatient, right? Which is good because part of the reason why people quit the IV-IP arm is that they were back and forth to the hospital for multiple days. Like they were spending probably 4 or 5 days over that first 2 weeks of every cycle in the hospital. Patients were interested in that. But interestingly enough, what was added to this was bevacizumab for all arms across all cycles except for cycle 1. Okay, and so there's a question about whether or not actually bevacizumab in the study actually led to, here are the results of the study, completely negative, even for patients with microscopic residual. But again, I would not necessarily, yes, this is a negative study, But I don't think it's an equivalent study to GOG 172 or 114 because the chemotherapy regimens used, the patterns of administration, doses, and then the addition of bevacizumab actually make this a very different type of trial. It's telling us conditions under my take on this is that this is telling us conditions under which intraperitoneal therapy may not work, and it raises some questions about whether or not we should be combining intraperitoneal chemotherapies with bevacizumab. In particular, if you line up all these studies, again, it is clear that patients do the best, okay, when you've been able to debulk them to no visible disease. So looking at stage 4 patients, the median progression-free survival here comparing, again, here the patients who did the least, that did the least well in these studies in both 114 and 172 were the patients who received only IV cisplatin or IV carboplatin. Okay, again, very relatively similar progression-free survivals. Here in 172, you see a progression-free survival for IP chemotherapy of 60.4 months. But again, when you get to IP, GOG 252, IP carbo IC cisplatin actually does very poorly, right? But again, what you don't see, okay, in each of these earlier studies, you see an enormous benefit from a patient having undergone debulking to microscopic disease that for whatever reason, okay, didn't show up in this GOG 252 study. So there's something very different about how these patients are responding and doing in response to their treatments. And again, to me, raises some questions about whether or not we should be integrating bevacizumab into these treatment plans. And so I think I'll stop right there and see if anybody has any questions.
So actually, because of time, we're going to pause the Q&A. Matt will be around, so you can ask your questions to him in a bit. And we'll go to our next speaker. I would like to introduce Dr. Annalisa Di Feo. You can just clean up here. You're already logged in. So Annalisa is an associate professor in the Department of Pathology and OBGYN in the University of Michigan. She is also the associate director of the Cancer Biology Graduate Program. She is an ovarian cancer translational scientist, and her research spans the continuum of translational aspect with in-depth analysis of patient tumors through functional assessment of genetic drivers and development of novel therapeutic approaches. Annalisa is also the director of the Michigan Ovarian Cancer Science and Innovation Consortium. So welcome, Annalisa.
You need an external? We have an external.
No, I'm thinking I have to log into my Michigan account.
Oh. Why do if we're posting the recording percent, maybe we do some questions for Matt?
Yeah.
Okay? Go ahead.
Very, very interesting work. Have you looked at pulsation? So instead of continuous treatment of HIFEC, pulsating it?
You mean over time or just?
So incremental, like instead of continuously, you do the process, then you stop, and then you do it again.
So yeah, so that's interesting. So that's an question, like feeding it, pulsing over time. We have not, and there's not a lot of data on that. Actually, interestingly enough, like so, for example, there are some clinical trials I think that are really kind of coming back around. Therapy they're going to utilize an intraperitoneal approach actually, and I think that creates a number of opportunities, right? And the fact that there's a group at Rice actually in Houston that just landed a $48 million grant actually from the NIH where they look at like a sensor which you place in the peritoneal cavity to sort of detect kind of a flare of your cancer with the goal of pulsing immunotherapy, which I think is a great, okay, except, immunotherapy, ovarian cancer doesn't work so great, okay, at least with immune checkpoint inhibitors. And so yeah, there's all kinds of potential options coming down the road.
Thank you.
You're all set, and
Is that the biggest thing?
Yes.
Oh, okay. Just want to make sure. Sorry. Sorry. Hello, everyone. I'm so excited to be here. As was mentioned, my lab is an ovarian cancer lab. So these types of symposiums are the most exciting to me because most of the cancer symposiums that I go to, ovarian cancer unfortunately makes up the smallest percentage of talk. So when it's an ovarian cancer symposium, I get really excited. So really, I try to kind of summarize some of the experiments and projects that are going on in my lab. And really, this first slide highlights the overall mission of the lab. And what we try to do is really put the patient first, and all of the projects are driven by the patients. So our lab really tries to utilize all of the patient samples that we acquire. So over the last 12 years that the lab has been established, we utilize patient samples that we get from the OR. I've been in New York, I've been in Cleveland, and now I'm currently at University of Michigan. And it's really through the collaboration of great clinicians, gynec surgeons, and pathologists that we acquire these samples. And with these samples, we generate cell models, either 2D or 3D. We generate PDX samples. And then we also obviously collect these samples to do molecular profiling. Through numerous collaborations with companies or other labs, we also use AI predicted models or bioinformatics and or novel drugs that they've developed to uncover or assess whether these drugs can be effective in ovarian cancer. Or we do tumor profiling in our laboratory to determine what are the molecular drivers of high-grade serous ovarian cancer, which is the cancer we primarily work on in the lab, but we do have some projects in other subtypes. After that analysis, we spend the majority of our time, as you can ask many of the people in the lab, understanding what the mechanism of these drugs are or what the drivers of that we uncover are. And then ultimately, the goal is to uncover personalized medicine. I think it was very telling that the last talk was a lot on chemotherapy and uncovering and the use of that and other modalities and trying to combine chemo with hopefully novel personalized drugs that hopefully we can determine or together, because I think that's one area that is lacking in ovarian cancer, and you'll see that in the next few slides that I show. So in this presentation, though, given that it's only 30 minutes, I really only have time to give really two quick stories and two projects that we're working on in the lab. So the first is going to really highlight the use of the mouse avatars that we have and the patient-derived cell lines in collaboration with another lab that's developed a unique drug that targets a tumor suppressor gene that's lost in high-grade serous ovarian cancer. So to quickly highlight the tumor bank that we've developed and the models we've developed. So over the course of the years, we've collected over 400 high-grade ovarian as well as high-grade endometrial cancer. So as many of you know, high-grade endometrial cancer is actually increasing over the course of the years, and actually one of the only cancers that's increasing in recent years. So we do collect also high-grade serous endometrial cancer. And through that, we've developed a number of PDX models and have genetically and histologically characterized these lines. We've developed TMAs for these. So we have the patient and the PDXs on TMA so that we can quickly look at protein expression. So if we're looking to do drug studies for drugs that target proteins, we can quickly determine what PDX models to use. And then we've done gene expression analysis to compare the patient tumor with the PDXs to confirm that there's similarities between the models. We've also done various drug studies with drugs that are currently being used in patients, such as platinum and Taxol, to show that there's similarities between the patient response and the PDX response. So given that, the first thing I want to, quickly just go over, because I know previous talks highlighted this, but for those that may not be as familiar, just the trajectory of how ovarian cancer is treated and what the history is, but many years ago is radiotherapy. And then with the discovery of platinum therapies in the early 80s, that's primarily been the chemotherapy that's been used and is currently being used in different ways, whether it's neoadjuvant, adjuvant, or with HIPEC. And really where I work is in the targeted therapy area, because I'm a geneticist by training, and I really feel that we need to find more drugs that are specific to the tumor subtype. However, if we look at ovary cancer, there's really only two classes of targeted agents that are approved, VEGF and PARP. If you look at other cancers, there's numerous, right? So why is that? Main reason is that if we look at the recurrent mutation rates in high-grade serous, they're very low. Other than P53, which we know is pretty much the hallmark of high-grade serous cancers, and BRCA1 and 2, which is why PARP inhibitors are effective, the recurrent mutation rate is very low. However, what we do know is the hallmark is genomic instability. So if you were to look at the overview of high-grade serous, you can divide them into a pie, whereas 50% of tumors are HR proficient, meaning they have a defect in BRCA or other HR genes, and the other 50% does not. So how can we develop drugs that could potentially maybe work in conjunction with PARP inhibitors so that they can make the HR deficient tumors that become PARP I resistant more amenable to PARP inhibitors, or maybe make these HR proficient tumors look like they're BRCA-like. And that was the idea, because we had collected many patient tumors and we had these models that were either PARP I resistant or that we knew had a BRCA mutation but did not respond very well to PARP inhibitors. And the way that we went about this was we were collaborating with a group, the NARLA lab at University of Michigan, that worked on a activator of PP2A. PP2A is a tumor suppressor gene. It's a phosphatase that we uncovered was commonly lost in high-grade serous cancer. So PP2A is a heterotrimer, and one of the genes that is a scaffold, as you can see here, is actually lost in 50% of high-grade serous cancer, high-grade serous tumors, almost as much as very well-known BRCA2, which was mentioned extensively, BRCA1. But more importantly, when you look beyond that, so as I mentioned, PP2A is a heterotrimer, and it's made of a lot of different genes. If you look at a number of the genes within the PP2A family, almost 100% of tumors have loss of one of the PP2A genes. And it is known by a number of different groups, such as Ronnie Dropkin, who works on the tumor genesis of ovarian cancer, that loss of PP2A, one of the genes that PP2R1, can cause ovarian cancer. So this was very telling to us. And most importantly, as you can see, the other allele of PP2A is not mutated. So it does somewhat make an ideal candidate that if you can reactivate this tumor suppressor, there is a suggestion that that could be an ideal therapeutic target. And just to quickly go over what this phosphatase does, it is a phosphatase that's known to control greater than 40% of the proteins in the cell, and it dephosphorylates a number of different genes and proteins. Some that you may know are MYC, AKT, EGFR, and so on. But I think the next slide may quickly highlight that. So the drug that they developed, this is the heterotrimer. We call it small molecule activators of PP2A. And what it does, essentially, it stabilizes the heterotrimer so that it's able to activate them. And therefore, it allows it to do and perform its tumor suppressive activities and induce cell death. And what we focused on in our project, given that we're working with high-grade serous cancers and we know they have defects in DNA repair, we were interested in seeing whether activation of PP2A would make these tumors that are not BRCA deficient look like they're BRCA deficient if it potentially could dephosphorylate and degrade these HR proteins. And what a great graduate student, now a postdoc in the lab, Rita Aguilar, did, she took our patient-derived cell lines that we generated and essentially ran some, MTT assays across a panel of these patient-derived lines. Here's a panel just looking at first that platinum response, and as you can imagine, the response to platinum was variable. But interestingly, the response to the PP2A activator was actually a lot tighter, suggesting that we actually had a better response to activating this phosphatase than you would get in response to platinum therapy. I'm not going to go over all the data because it is published. We do show that these PP2A activators are more effective regardless of platinum resistance. So they respond both in platinum sensitive and platinum resistant cells. But most importantly, I want to talk about the PARP inhibitor resistant cell lines. So these are two different PARP inhibitor resistant lines. This is one that we made in our lab. OV81 was a patient that was initially sensitive to platinum. And then actually we made the cell line resistant to platinum by exposing the cell line to 40 passages of platinum. And what we found is that the cell line became resistant to platinum, but it also became resistant to PARP inhibitor, which is a commonly seen phenomenon given the pathways that the two regulate. And here's just showing a MGT curve as you expose the cell to a PARP inhibitor. So CP40 is more resistant. And these are the commonly used PARP inhibitor resistant lines, PEO1 and PEOC4. The reason these are PARP inhibitor resistant are because they harbor a reversion in BRCA. So one of the lines is BRCA mutant, and the other common way to become resistant to PARP inhibitor is that they actually, you get a reversion in the BRCA gene that they now re-express BRCA. So they become resistant. So what we did, we now treated these lines with our compound, the PP2A activator, in combination with the PARP inhibitor, and we show that in combination, you can sensitize these lines to PARP inhibitor. And this is just some of the data to show the combination index and that you get a synergistic effect when you combine the two drugs in the models. So the mechanism behind this, which took an extensive amount of time, and again, I don't have all the data here because it is published. Rita looked at a number of HR proteins, and indeed, the most significant and the earliest HR protein that was degraded was RAD51. And this was very interesting to us. And actually, a recent paper came out showing that RAD51 is a marker of platinum resistance, was that SMAC treatment alone was able to reduce the expression of RAD51. And then as you can see, in combination with PARP inhibitor, you get a reduction in RAD51 and an induction of gamma H2AX, which is a marker of DNA damage. And in combination, you get an induction of apoptosis. But most importantly, we needed to show that this was dependent on the activation of PP2A. So in order to do that, we can use this calculin A, which is an inhibitor of PP2A. So in this study, you just treat with the SMAC, which is a PP2A activator. Then you can co-treat with calculin A, which is an inhibitor, and you can rescue that phenotype. And you no longer get the cell death. So really the proof is in the models. First, let me just kind of clarify the mechanism that we showed in that paper, right? So essentially, as mentioned earlier, a hallmark of ovarian tumors is genomic instability. And it's really because the first hit that high-grade serous that we see in high-grade serous are P53 mutations or BRCA mutations. So they have this baseline genomic instability or DNA damage. So gamma H2AX is essentially always there, but luckily cleared. And that's cleared by the sensors and RAD51. So you always have a low recruitment of RAD51. But unfortunately, if, and that RAD51 recruitment obviously is able to repair the DNA damage and self-survive. But if you then activate PP2A and inhibit that RAD51 then allows the accumulation of gamma H2AX and DNA damage, and therefore leads to cell death. So now the most important were the multiple PDX studies. These are two of them that we had in the paper. So this is the OV81 study where this patient is BRCA wild type and did not respond to olaparib. I'm not sure if you can see the fonts because I was back there, couldn't see so well, but the blue is the vehicle, the yellow is olaparib, and essentially the PDX did not respond. If you treat with the PP2A activator in red, you get a response, and then in the green, the combo. You don't necessarily see regression. I wish we had gone out longer, but this is in the thousands, sorry. But we had to stop the study because the controls were getting too big. And now here is a patient that had a BRCA2 mutation. As you can see, with the olaparib or SMAP alone, they do respond, but in combination, you get regressions actually. in that model. And we saw the same thing in a BRCA1 model. And then we also stained the tumors for gamma H2AX to confirm that we're getting induction of gamma H2AX in vivo. So in summary, this project really, we wanted to highlight how we could utilize these novel patient-derived cell lines and PDXs and collaborations with individuals that develop these unique tools and drugs and genetic information that we know from these high-grade serous patients to uncover novel potential targeted agents for ovarian cancer. In addition, it was a tumor suppressor gene that we had known about, but it's a very intricate one because there's multiple subunits of one protein that I think we didn't essentially analyze initially. So we are now collaborating. So this compound has been licensed to Raptor Therapeutics. They did acquire Series A funding through Novartis Ventures and Novo Holding. And what's really great as a PhD scientist, this has influenced their clinical lead. So they're now looking to move forward in ovary cancer. I didn't show, but this PP2A is actually commonly at least 30% of the time mutated in uterine serous cancers. So the other clinical lead, we have a lot of data actually in our PDXs for uterine serous, is uterine cancer. So based on our PDX studies, they're moving forward in those cancers. So that's really great and exciting for us. So the quick second study that I want to go into is now how we utilize our patient samples to do tumor profiling and find new drivers that were not necessarily identified before, and more importantly, that are not genes. So another passion of mine is looking at microRNAs. And why? So again, as I keep on highlighting, genomic instability and a high degree of genomic disarray is a highlight of ovarian, hallmark of ovarian tumors. So what does that mean? So this is just looking at the genomic landscape of gynecologic tumors and breast cancers, right? So in green are the ovarian cancers, and you can kind of see that they pop out. And the reason being, red indicates amplification, blue is loss. And you essentially see gains and losses all throughout the genome, from chromosome 1 to X, right? So why that was interesting to me is because when I started my lab, right out of grad school, there was someone that was an expert in microRNAs, and it was the hottest thing at the time. And I said, well, I was shown that microRNAs are in these hotspots of gains and losses. So could it be that this genomic instability is amplifying or deleting microRNAs that are critical to tumor development, number one, and also to prognosis or stemness or selection of really bad players and in ovarian cancer progression? So essentially, this just gives a quick little synopsis of what microRNAs are for those that are not as familiar with them. So microRNAs are one of the most abundant regulatory molecules in our cell. And really, they are most innate molecules in our cell, and they develop because they're important during development of the embryo, and they regulate, they fine-tune various genes in our cells, and they could regulate over 300 different genes, which is important in a cancer cell, right? Because it's not one gene, one pathway that regulates, unfortunately, cancer cell progression. And the other thing, as I just mentioned, they are commonly associated with regions of genomic gains and losses. And secondly, why I found it very important to look at, as was mentioned previously, the large majority of ovarian patients are diagnosed at stage 3 and 4. And we still don't have a biomarker to detect it at earliest stages. And these microRNAs are highly stable in blood. So if we could find a microRNA that's released at stage 1 or even stage 2, that could potentially be a great diagnostic biomarker. So how did we go about uncovering microRNAs that are relevant? Again, we started with our patient tumors. One subset that we looked at was we had primary patient tumor, and then we had tumors from these same patients if they were recurrent and resistant to chemo, platinum Taxol. And we looked at the expression of this microRNA-seq, which is just small RNA-seq rather than looking at genes. And we found that this one microRNA family, this miR-181 family, was induced. We saw about a 2.5-fold increase in miR-181. We then also looked at our patient cell lines As I mentioned, we make a lot of cisplatin resistance lines. So any line that says CP is a line that's cisplatin resistant. And consistently, we saw that there was an increase in this microRNA 181 in the cisplatin resistant lines. I just realized I should probably use my pointer for the people on Zoom. Sorry. I like to walk around. And then in numerous cohorts, I'm not going to go through now, we then looked at another cohort of patient samples, and we want to see, well, this increase in 181 in the resistant lines correlates with outcome. And when, indeed, if you dichotomize at the median expression of microRNA 181 expression, you can see that tumors that have high expression of this microRNA correlates with poor progression-free survival and overall survival. And what was most interesting and exciting for us is that in an independent study out of another group, they then did a multivariate analysis with 5 independent ovarian cancer patient cohorts. And what they did here was compare 181 expression with known prognostic biomarkers. And they looked at mere 181 expression, now comparing it to residual disease and to platinum response. And they looked at, even in patients that had less than 10 centimeters tumor remaining, which are typically patients that do very well, if those patients had high 181, they actually had worse outcome. And they saw the same thing in patients that had complete response, partial response, or stable disease. Even in that cohort of patients, if they had high 181 expression, they did also significantly worse. So this highlighting that high 181, even in patients that normally would do well, had some distinct phenotype that made them progress. So that's why we did, I mean, obviously we're already spending a lot of time working on this microRNA, but it highlighted our hypothesis that this is something that's driving cancer progression, and also the need for maybe identifying a therapeutic target. So how did we uncover, or how did we work on trying to figure out what this microRNA was doing? We used this microRNA biosensor. So these biosensors, you essentially could utilize the mCherry 3' UTR promoter. And what you do, you put microRNA binding sites at the end. So then when the microRNA 181 is present, it represses mCherry. And therefore you can look at mCherry expression as a functional readout of the microRNA. And here's just highlighting when the mCherry is low, you have high 181, and when mCherry is high, you have low 181. And then here's just a graph looking at 181 mature expression, essentially highlighting the correlating mCherry expression with 181 expression. And most importantly, this data, this is already published, but I just wanted to highlight, we can sort primary cell lines or established cell lines based on 181 function. And what we found is that 181 high cells had a higher ability to form tumor initiating cells or stem spheres. And most importantly, when you put them into mice, 181 high cells form tumors faster, and those tumors were able to grow indefinitely compared to 181 low population. As I mentioned earlier, we were also interested in looking at tumor initiation. So in collaboration with Ronnie Japkin, we acquired primary immortalized fallopian tube cells from women. And we wanted to determine whether re-expression of 181 in these fallopian tube cells, which are the precursor of high-grade serous ovarian cancer, would actually transform them. And what we found was it did. And remarkably, the control cells do not grow tumors, but when you re-express 181, they do. And most importantly, when you then knock down 181, they no longer form tumors. And we found out that the mechanism by which they were able to do this was the most significant pathway that was repressed in these lines was the interferon signaling pathway, which at first was very confusing to us because this was done actually in a cell line in a dish. So how was it doing that? Getting back to gamma-H2AX, when you overexpress 181, this is looking at gamma-H2AX, it induced a significant amount of DNA damage. So genomic instability, a lot of DNA damage. But what happens when you have a lot of DNA damage, you actually alter the nuclear structure. So that's actually what the nucleus of the cells look like. And then when nucleus looks like this, that causes nuclear rupture. And this, I don't know if this is gonna play, but you can measure nuclear rupture using a GFP. Oh, yes, you can. So the green is a green fluorescent protein that should stay in the nucleus. But as you can see, when you overexpress 181, number one, you could see the shape of the nuclei is completely abnormal. And then it actually ruptures periodically. And essentially, when a cell senses DNA in the cytoplasm, that would trigger an innate immune response, because that is a foreign, DNA, and that would indicate that there is an attack or a pathogen, right? And that should trigger something called the STING signaling pathway. So what we've uncovered was that 181 significantly represses this STING signaling pathway and the innate signaling pathway. So the way that 181 is able to transform these cells is by suppressing STING and the innate signaling pathway to allow for transformation. So in sum, after numerous years, we found that 181 is involved in essentially the entire progression of ovarian cancer pathogenesis, and it's able to do that through multiple steps and by regulating various genes throughout the continuum of ovarian cancer. And I think this highlights the power of microRNAs. It's all dependent on the context. So we did not find that STING repression in ovarian cancer cells, and that's primarily because STING expression tends to be relatively low in ovarian cancer cells because it's already lost. They've already lost that innate immune ability. So when we looked at 181 targets in STING in ovarian cancer cells, STING was not present, so it wasn't targeting STING anymore. However, in fallopian tube cells, STING is high because it's protective. So now, where did we go from here? This really led us to that 181 is potentially an ideal target. I already highlighted the clinical relevance by our work, other groups' work. Most importantly, there's several papers now. There's low expression of 181 in normal tissue. I don't have time to show you this, but there's 3 papers that have come out that have crossed the 181 knockout mouse. So the 181 knockout mouse is viable. And there's a group that have crossed this mouse with the P53 KRAS mouse that developed pancreatic cancer and lung cancer. And they show that it improves survival and decreases tumor growth. So that's highlighting that obviously loss of 181 is involved in the progression of those very high, and that model is a highly aggressive model with KRAS P53 driven. And as I mentioned, 181 is regulating a lot of these key pathways, as we heard earlier as well, that drive ovarian cancer. So the first thing we did was inhibit 181 in a number of different cell lines, both mouse and human. We wanted to include mouse, given its regulation of an innate signaling pathway. And as you can see here, just in this one ovarian cancer cell line, inhibition of 181 does lead to upregulation of STING, which is the opposite of what we had seen. And this is just the downstream mediators of STING signaling pathway. But most importantly, when you activate STING, what you need to see is activation of the interferon signaling pathway, because that's then what mediates the immune signaling pathway. And what we saw is that in all 4 lines is that we get an upregulation in all the cytokines and chemokines that are regulated by STING. So what does this mean in the mouse? So the first study that Shrija did, who's a postdoc in the lab, she just injected these murine syngeneic mouse models, ovarian cancer cells. So these mice have a competent immune system subcutaneously to see, does it affect the tumor growth? And it didn't actually, which we predicted, because 181 overexpression does not affect proliferation, just rarely does, because it actually regulates TGF-beta, Wnt, state. So it actually, in all of our previous data publications, it's more stemness and EMT. So we did not see a difference on tumor growth sub-Q. But what we did see, which actually made her upset at first, but lo and behold, when she sacked the mice, the control mice Very high percentage had metastasis in ascites, but none of the 181 knockdown mice. These are now stable overexpression because we don't obviously have a drug for 181. None of them had metastasis or ascites. And we did confirm that they still had knockdown of 181. Okay, then we have one other study. So now that we knew that these metastasized, we then did an IP study. We actually went straight to a metastasis study. We injected the cells day 0, and then on day 7, we injected either the scrambled controls, so they stably knock down a scrambled sequence, or they stably knock down your 181. And we also this time, so STING, obviously as I mentioned, activates the innate immune system. So there's actually several pharmaceutical companies are trying to use this as a cancer therapeutic. So one of them is Merck. So MSA is a compound that Merck is currently developing, is a systemic STING agonist. So we utilize that to compare to our 181 inhibition and also to combine them to see if 181 inhibition could potentiate the effects of the STING agonist. So here on day 7, we treated with the MSA agonist as well as day 10 and 15. As you notice, you cannot continuously treat with a STING agonist because you'll get autoimmune effects, right? You can't on a cytokine storm. So this is on day 7 when we started treatment with MSA. And this is now on day 37. I hope you can already see that the MSA treatment was effective. Even just 181 knockdown, and remember the cell lines are the only ones that have knockdown 181. The mouse still has 181 present. And then in the combo, essentially, which was really, really nice, you had complete regression of the tumors. And then this is at the end of treatment. We did not get tumors coming back in 3 of the mice. And this is, I think, we had done survival analysis. The other thing for 3 of the mice that did not have tumors coming back, we did re-challenge them with the cells. And only 1 of the mice had their tumor come back, suggesting maybe there's an effect on memory T cells. But this is an ongoing study. And now just to wrap it up, so where do we go from there? As I mentioned, these studies are more proof of concept, right? That you can inhibit 181 and you have effects on growth and you have potentially regression in combination with STING agonists and potentially alone. But we need to find a drug that would inhibit this microRNA. So now what we've done, we've developed a small molecule high throughput screen. So what we've done, we now, as I mentioned with that biosensor, we could isolate these 181 high cells. And this is critical to the screen because what we've done is you select cells that are addicted to 181. And then we do a high throughput screen with the libraries that we have at Michigan Drug Discovery Institute. I just want to highlight that here. So you use a sensor, you have the 181 low. And what's nice in the screen, you're therefore looking for an increase in mCherry, which I feel that on these high throughput screens are important because sometimes when you're looking for a decrease in fluorescence, just killing the cells, you can sometimes have a false positive. And this is just an example of what we see using our positive control, which is your antagomer, which is essentially an siRNA. You can appreciate that you have a nice increase in mCherry when you knock down 181. And this is work that Grace Jose, postdoc in the lab, initially started, and now Grace McIntyre, who's a grad student in the lab, has now completed. I'm so excited. We're at our final 32 candidates. So we have screened close to 55,000 compounds, and the percentages are essentially our hit rates. And we have now at the last 32 validated compounds. And what's nice, 12 of the 32 are predicted to bind RNA. Within these 32, we have 2 clusters that were identified. And we're now up to the orthogonal screen. So this is the hard part. Some of the stuff we will look at is how specific are these compounds. So this is an idea of now looking at the expression of microRNA 181. So like for instance, these 3 compounds, we do have decrease of 181A. This one, for instance, knocks down, decreases these 2, also 181B and miR16. These 2 seem more specific to just 181A. And then this is really important. So 181 promoter is highly regulated by Wnt, TGF-beta, and I mentioned that, STAT3. So we want a compound that is not affected transcriptionally because we feel like that will then affect a lot of other genes. So we also do promoter assays with these compounds. So we have some compounds that do affect the promoter and some that do not. And then we've done some potency. So we have some non-transcriptional compounds that are pretty potent and some transcriptional compounds that are. So in summary, I think with this part, we do show that 181 is a novel biomarker. And actually we're working with Kevin Elias at Harvard. He really works on microRNAs in serum, and this is part of his panel. So we don't think 181 alone might be a biomarker, but maybe in conjunction with a panel of microRNAs that are involved in the earliest stages. And he looks at it, he has a beautiful cohort because he has a clinical trial looking at BRCA mutant and BRCA wild type patients and serum microRNAs. And I think it really highlights that with these 181 high tumors, especially in that clinical data and that clinical cohort, they probably have a worse outcome because of they're driving these really potent and aggressive phenotypes because they're driving these things, TGF-beta signaling pathways, and that inhibition of this pathway is potent. So with that, I just quickly want to highlight the thank yous, and really thank you to the sponsors of this program and the symposium, MIOCA, Mass Mutual, and I thank you guys for inviting me. I'm happy to meet you in person finally. And most importantly, the lab, everyone that did all this work. It's such a joy to work with them. I always try to present on everyone's project. I'm sorry for everyone that I don't get to present on. And then really all the collaborators that I work with and the funding agencies. And the patients, most importantly, because like I said, they drive all those projects. And that's it.
Thank you, Annalisa. I think we have time for one question before we go on the break.
I'll ask one. Hi.
Yeah.
So I'm really glad you're also looking at the uterine disease site, right? Because nothing against ovarian, but there's a big, if you're aware, for high grade endometrial, they've fallen behind in terms of that. So glad you're looking at that. I was wondering if same histology, different disease site, have you preliminarily seen any differences with respect to the disease site variable in your research?
So all of and it's, why we even have we have a lot more even PDXs in serous endometrial because of this, a guy on Surgeons when I was in Cleveland. They're like, we're seeing so many of these, can you start collecting? So when you say disease sites in terms of the
so you're looking at high-grade serous carcinoma, any head-to-head, like coming from ovary versus coming from the endometrium?
I don't know if we haven't really done a comparison. Are you talking molecular comparison, like gene path? We can do it. We have not. One thing I will say, there's a reason we have more PDXs because we implant them all. There might be, we go where the data takes us. So if you think about the stemness, and what we know is that PDXs grow because of the tumor initiation capacity. So the fact that we have more PDXs from that subtype and those tumors could suggest there is a unique feature that we probably should go after. I will also say a lot of those serous samples are from Cleveland, and 30% of those are from African-American women. One other study that I've been waiting for someone to do is look at the genetic landscape because it's all from the same hospital. They're all treated by the same clinicians. It is a pretty clean subset so we haven't looked at that profiling yet. But yeah, no, it's a great question. We just don't have the bandwidth to look at it yet.
Thank you. It's a beautiful talk. You went quickly in that you said that one of the pathways that were activated, the interferon. Yes. This is specifically the type 1 interferon.
Yes. Yeah.
Type 1 interferon. So many of the responses of interferon beta, especially in alpha, the DNA damage or any damage inside a cell is a stress response to activate the stinks.
Yes.
But sometimes you don't need to have high levels of interferon, especially interferon beta. And I don't remember if I saw changes in the levels of interferon beta when you look at the arrays.
So we did, so I just didn't include it all. We had a whole panel in
Yeah.
I only included the Z-score, I think, but if you
Okay.
go through the paper, we have the gene expression of the interferon beta. And we we've now following up with other projects in the lab looking specifically at interferon beta.
Got it.
Yes,
Okay,
yeah,
it's a very important.
it is. No, I agree with you. We even have the interferon beta reporter looking at it. And also the other thing that we think is important, we're trying to distinguish the NF kappa beta arm versus the IRF3 arm, because I think they're both,
Separate.
yes.
I have to talk more.
Yeah,
Very nice.
no, I would love to.
So thank you, Annalisa. All the speakers are gonna be around, and for now, we're gonna break, maybe 5 minutes coffee break, and come on right back for our keynote speaker. We have coffees and drinks in the other thing.
There was one thing in the chat.
I said,
Thank you.
Can you?
Nice to meet you, Michael.
Is
For the, you know,
permitting somebody?
Nice talk.
Thank you.
Is it possible?
So you're gonna connect to Zoom when it's your turn.
By the way, Alexa did it. Because I need to.
That's
Thank you so much, Aisha. I'm not worthy of that wonderful introduction. And thank you, Dr. Moore, for inviting me here. I didn't know much about the Mott Center, and I have to say I'm really impressed. Thank you for the supporters of the conference. I just came from AACR Ovarian Cancer Conference, which was last week in Boston, and I thought that I had learned everything about ovarian cancer, and I didn't need yet another ovarian cancer conference, but the three talks before me that were totally different than what I had heard in Boston, and I took copious notes, so it's really a high-level conference. Thank you for inviting me to be part of it. So over the next hour, I will talk to you about the new direction in our laboratory, looking more at metabolism in ovarian cancer. I think the crowd here is well familiar with ovarian cancer, but I do have a couple of introductory slides. As you know, ovarian cancer is kind of a misnomer. The origin of ovarian cancer, it's in the fallopian tube, with the P53 mutational signature being one of the initiating events, along with probably oxidative stress and inflammation that contribute to genomic instability and the transition of the normal fallopian tube epithelium through the P53 type secretory cell expansions, thick lesions leading to carcinoma. And I had to include this figure because one of the students in the adjacent lab made it, and I thought it was very nice. He spent quite a bit of time. And as you all know, the genomic signature of ovarian cancer and of the different specific subtypes of ovarian cancer has been increasingly deciphered and dissected in the recent years. And we now know that the different subtypes of ovarian cancer have different mutation and genomic features. And the same student made this figure, which the journal rejected. They wanted a table, but I think it's a really nice figure, so I wanted to show it. And we know that, you know, the TCGA was expected with much anticipation for the part of the field, and it was disappointing as Ana Maria Annalisa mentioned that we didn't find any really kind of mutation drivers or to subtype ovarian cancer, but what was found as the main feature of high-grade serous ovarian cancer was the division of these tumors in homologous recombination deficient and homologous recombination proficient. And although we were not able to subclassify high-grade serous ovarian cancer based on mutation status, I think that this is a key finding that has really pushed the field forward with the advent of PARP inhibitors and the impact that they have made for at least HRD ovarian tumors. I think this is one of the first steps to cure in ovarian cancer, something that at the beginning of my career I didn't think was achievable. So most of you working in cancer are very familiar with the evolving paradigm of hallmark in cancer that adds every few years a new hallmark. And one of the things that has piqued our interest has been understanding deregulated cellular metabolism in high-grade serous ovarian cancer and whether this could represent a therapeutic option or a therapeutic vulnerability. We know that in cancer, the abnormal metabolic profile is driven by both genetic events, particularly oncogenes that drive the cancer, but also by the tumor microenvironment, by hypoxia, acidity, availability of nutrients, and so forth. And this abnormal metabolic profile will reflect in the way cancer cells utilize energy, synthesize key metabolites, and regulate redox. And this slide, associating obesity to ovarian cancer is not unique to ovarian cancer. In fact, there are other cancers, such as uterine cancer, where this association is even stronger. But even in ovarian cancer, there is an association between ovarian cancer and body mass index, and also between ovarian cancer incidence and visceral obesity as measured by abdominal circumference. And we know that the most common site of metastasis for the clinicians in the room is the omentum. This is a fat-rich organ. And this seminal paper from Ernst Lengyel's group from 10 years ago, I think is like his best work that stood the passing of time, shows that the ovarian cancer cells and the adipocytes live in a symbiotic relationship, and that the transfer of free fatty acids between adipocytes into the cancer cells is so important for the generation of energy that the cancer cells need in order to proliferate and also to metastasize. And in this paper, he pointed to FABP4 as one of the key proteins that mediates this transfer. And since that time, more research on lipid metabolism has happened in the field. CD36, which is a lipid transporter, has been shown to be also involved in ovarian cancer progression and metastasis, also from his group. And also this fatty acid receptor, CD36, was found to be a key receptor for metastasis initiating cancer cells with stem cell properties in other cancer models. I think in this model was head and neck cancer. So with this kind of background, my laboratory has been interested to understand lipid metabolism alterations as they relate to development of platinum resistance, as they relate to cancer progression and to cancer stem cells. And to kind of refresh a little bit your memory about lipid metabolism, there is lipid import right through the transporters and then mediated by the fatty acid binding proteins, bringing these fatty acids within the cells to be either stored in lipid droplets or utilized for through beta oxidation. But in the absence of import, if nutrients are limited in the tumor microenvironment, that the cancer cells synthesize lipids through the process of lipogenesis, starting from citrate acyl-CoA through the activity of fatty acid synthetase that leads to a generation of saturated fatty acids, which ultimately will have to be desaturated through the activity of fatty acid desaturases. And what I'll show you today is some of our work on fatty acid desaturase, SCD, and the role of lipid import as well as lipogenesis as they relate to chemoresistance. So this work started as a partnership with a physicist who was at Purdue and subsequently moved to Boston University. He's a pioneer in the area of hyperspectral stimulated Raman scattering microscopy. And basically this technology, laser, is projected on living cells. It's collected through a series of optical systems and transformed into one of these waves. And the peak of the wave, the location, the width corresponds to the biochemical composition of the cells. And obviously this is a very high-level presentation of SRS microscopy. I'm not an expert on this, but Jishin has been a wonderful collaborator over the years. And this technology is uniquely suited to study lipids in living cells. Our laboratory has had an interest in studying the cancer stem cells, which are rare cells within a tumor that have the ability to generate daughter cells and initiate tumors. They are quiescent and they are typically resistant to standard treatments such as chemotherapy and radiation therapy. such that if one thinks about the heterogeneous tumor where you apply standard treatment with chemotherapy, this will debulk the differentiated cancer cells, leaving behind cancer stem cells. These cells can stay dormant for a period of time, and at some point, under influence of cues from the tumor microenvironment, they can reactivate and generate recurrent tumors. So one would imagine that if we have a specific therapy that would take care of these cancer stem cells, we could achieve a cure. So we and others have studied ovarian cancer stem cells by using various markers. The ones that we're currently using are based on Ron Vukanovich's group out of Michigan, now at Pittsburgh. He used CD133 surface expression and activity of aldehyde, aldefluor activity. And by using these two markers, we can identify this population of cells that has tumor initiating capacity. They represent anywhere from 2 to sometimes 10% of tumors or cancer cell lines. And indeed, we and others have shown that these double positive cells have sphere-forming capacity. They can initiate tumors when injected in small numbers in immunocompromised mice. And interestingly, they are also dormant. The positive cells have less EDU incorporation and proliferative rate. So together with Jixing, we first asked the question, is the lipid composition of these cancer stem cells different than the bulk cells, the differentiated cells? And we did this by sorting out ALDH CD133 positive cells and then subjecting them to SRS microscopy. And we found indeed that there were some differences in the spectra at 2,900 nanometers and at 3,000 nanometers. This eventually turned out to be kind of noise. We weren't able to reproduce it across cell lines, but the peak at 3,000 nanometer, which corresponds to unsaturated fatty acids, was reproducibly observed in cancer cell lines, as well as in cells, double staining cells that we generated from tumors. So what are unsaturated lipids? Unsaturated lipids have a double carbon bond, and one of the important enzymes that generates monounsaturated lipids is steroyl-CoA desaturase, in brief SED. This enzyme catalyzes the deposition of a double carbon bond at position 9, such that saturated fatty acid, palmitic acid, stearic acid are converted in monounsaturated fatty acids, palmitoleic and oleic acid. And this, the balance between saturated and unsaturated fatty acids is important for membrane integrity. It's important for cellular signaling, as well as for energy generation. So we measured this enzyme and found it to be somewhat increased in the cancer stem cells, and we used an inhibitor and were able to see inhibition of all the stemness characteristics, including sphere formation assay, ALDH expression, and expression of stemness-associated transcription factors. And furthermore, use of this inhibitor at low doses, non-toxic doses prior to injection of stem cells into animals suppressed the tumor initiation capacity of these cells, suggesting that the lipid unsaturation is important to the cancer stem cells. We went then a little bit further to study more the role of SED in ovarian cancer. We see that this enzyme is expressed in high levels in ovarian cancer cell lines versus the normal fallopian tube cells, as well as ovarian surface epithelial cells. And it's also increased in tumors profiled in the TCGA compared to fallopian tubes. and it's also detectable by immunohistochemistry. So Guangyuan Zhang did this work in my laboratory. He's a graduate student, and he recently graduated and went to Tempus as a scientist, but he was very rigorous in analyzing the function of SCD, depleted SCD in ovarian cancer cells, and as one would expect, upon depletion of SCD, you decrease these unsaturated fatty acids, whereas the saturated fatty acids were not affected. Then we did mass spectroscopy, spectrometry to find which lipid species were most affected, and found that phosphatidylcholines and sphingomyelins were the species that were most affected by depletion of SCD. And looking further at the composition of these phosphatidylcholines, we found that depletion of SCD, in fact, decreased the phosphatidylcholines with 1 degree of plasticity, meaning those that had 1 or 2 double carbon bonds, which is consistent with what one would expect given the known function of this enzyme. We struggled a little bit to try to figure out what is exactly the mechanism through which this depletion of this enzyme works, and we did RNA sequencing to find out what genes are altered, how the transcriptome is altered as a consequence of SCD depletion. Of course, we found thousands of transcripts differentially expressed when SCD was knocked down. But interestingly, when we put this into pathway analysis, one of the pathways that emerge is a response to endoplasmic reticulum stress. Multiple variation of this pathway were found. So ER stress is typically triggered by accumulation of misfolded proteins in the ER, and this can happen in cancer due to microenvironmental conditions, due to oncogenes driving uncontrolled cell proliferation, due to metabolic alteration in the tumor microenvironment, or due to cytotoxic therapy. And cancer cells respond to this stress by activating several pathways in order to survive. The time of exposure to ER stress, as well as the intensity of the stress, are key factors determining whether a cancer cell will survive, will be able to adapt and survive, or what if the stress is too prolonged and too intense, whether this will lead to cellular death. And there are 3 key pathways that are activated in response to ER stress, including PERK, ATF4, ATF6, and then ERE1 alpha. ERE1 alpha is a protein that's located in the ER membrane and is activated in response to presence of misfolded proteins in the ER lumen. It has 2 key activities. One is a kinase that leads to activation of NF-kappa B and JNK. And the second is endoribonuclease activity. And it basically splices the mRNA for transcription factor XPP. This splicing occurs in the cytoplasm and leads to formation of this short XPP transcription factor, which can go into the nucleus and is transcriptionally active. It will activate UPR target genes that help the cell overcome ER stress. So we looked at all of the different mechanisms, but I will focus on XBP, ERE1 alpha activation, and XBP splicing for this talk. When we depleted SCD, not we, Guangyuan. This is all his work. When he depleted SCD, you can see very clearly that there is increase in the splice, the short version of XBP compared to the unspliced form, And the same thing was seen when we inhibited the desaturase by using an inhibitor, and this was dose dependent. So we did a time course experiment and observed that the highest level of splicing occurs at 12 hours, and that this stress, in fact, is also accentuated when you inhibit the enzyme, the desaturase, but also add palmitic acid, like a saturated fatty acids, such that the balance between saturated and unsaturated fatty acids is further accentuated. Yeah, we looked also the PERK ATF4 pathway, and we see the same thing, depletion of SCD, as well as addition of palmitic acid leads to activation of PERK ATF4 as well. And we also looked by electron microscopy at how these cells look like. And if SCD is depleted, you can see that the normal structure of the ER becomes distorted. So we concluded that SCD is critical to maintaining the balance between unsaturated and saturated fatty acids, which is important to maintaining normal ER function, and that when SCD is blocked, you have more saturated fatty acids and ER dysfunction. So if this were the case, then one could reverse the ER stress by adding unsaturated fatty acids to the cells. And that's exactly what we did in cells where SCD was knocked down. You can see that the XBP is spliced, but if oleic acid is added back to the cell, this splice form goes away. Similarly, in cells where SCD is knocked down, and you add on top of that extra saturated fatty acids, palmitic acid, you have a lot of spliced XBP, but this is completely restored, goes back to almost zero when you give back the cells oleic acid. And why do we care? We care because this determines whether the cells will survive or die. And indeed, in cells where SCD is knocked down, there is increased apoptosis. The rapidity of the onset of apoptosis and the degree of apoptosis is increased if SCD is knocked down and palmitic acid is added. And this phenotype is abrogated when oleic acid is added back to the cells, suggesting again that this balance between saturated fatty acids and unsaturated fatty acids, it's critical to maintaining cell survival. So does this happen in vivo? We knocked down SCD and observed decreased tumor formation in an intraperitoneal xenograft model. And then we also tried to use the inhibitor, an inhibitor to SCD with the intent of transforming this into a more therapeutic option. The inhibitor led to some modest effects, but not full effects. And so we decided to do kind of a double experiment where we use the SCD inhibitor together with modifications in diet. So half of the mice were fed normal diet and half were fed saturated fatty acid rich diet, and they receive either control or the SCD inhibitor. And these are the results. In the controlled diet mice, there was modest effect of the inhibitor, not statistically significant. For the mice that were fed increased palmitic acid diet, there was increased ascites formation compared to the control mice, which had been reported by others that saturated fat have a pro-tumorigenic effect. However, when we used the saturated fat together with the palmitic acid, we were able to suppress ascites formation as well as numbers of metastases. And the tumors were harvested and then processed ex vivo, and you can see that in the mice that were treated with the desaturase inhibitor and fed the palmitic acid diet, a kind of a double hit in the same pathway, there is increased evidence of ER stress in those tumors with increased splicing of XPP. So what I've shown you so far is that cancer stem cells are enriched and depend on more unsaturated fatty acids, that the cancer stem cells are susceptible to inhibition of fatty acid desaturases. The balance between saturated and unsaturated fatty acids is important to cancer cell survival and tumor growth, and that disrupting this balance impacts tumor initiation and progression. Another key question that my laboratory is interested in, and that's because I'm a medical oncologist and I treat patients with ovarian cancer, and typically the surgeons like to treat the patients right after surgery when they're doing great and they're going to have a complete remission, and then they refer them to me when they recur and they don't have such a good outcome.
That has to do.
No pun intended. Is how does lipid metabolism is involved in response to chemotherapy. So platinum resistance is a significant clinical problem. Unfortunately, the majority of patients with advanced disease will reach this point, perhaps with the exception of the BRCA2 mutated patients that will get PARP inhibitor in the upfront setting. And unfortunately, response to chemotherapy in the platinum resistance setting is quite limited, with anticipated survival of less than 18 months, which is better than it was 5 years ago when it was 12 months. And the standard treatment for these patients currently is chemotherapy with bevacizumab and anti-VEGF drugs. So we've been interested in understanding what drives this platinum resistance. And many people over many years have worked on platinum resistance. There's a lot of literature that points to different mechanisms, from drug efflux mechanism to regulation of apoptosis to epigenetic mechanisms, genetic events that drive resistance, regulation of redox. So we decided to look at metabolism. And to do this, we use platinum-resistant models that we generated in the lab, the same way that Dr. DeFeo mentioned earlier, through repeated exposure to platinum, allowing the cells to recover and then hitting them again to platinum. And we're able to derive several cell lines. We have pairs of cell lines that are parental or platinum naive, and then we increase their IC50 to cisplatin and carboplatin by about 2-fold. And then we also use this isogenic sensitive resistance cell line, which I think is very relevant for the field. The PO1, PO4 cells. PO1 cells are BRCA2 mutated, and PO4 cells have a reverting BRCA mutation. And these cells have been established 20 years ago from the same patient. The PO1, the platinum sensitive, were derived at the time of the first relapse, which was a platinum sensitive relapse, and the PO4, and I think there's a PO6 as well, but we don't have them, were derived at the time when this patient developed a platinum-resistant cell line. So we use these cells together to kind of study the mechanism of platinum resistance, or maybe platinum tolerance. It's like an acquired resistance. And about the time we were starting to study this concept of persister cells has come about. And these persister cells were described kind of in the a field of receptor tyrosine kinase inhibitors, where these cells were shown to kind of reverse to a slow cycling state similar to stem cells. They have increased stemness markers, they have increased EMT markers, And then it was demonstrated that these cells are resistant to ROS because they upregulate antioxidant mechanisms. And they also undergo kind of chromatin remodeling, epigenetic remodeling. So we looked at our cancer cell lines, and indeed we found that after exposure to cisplatin and carboplatin, these cells have increased stemness characteristics. They can form more spheroids, they have more ALDH, they have more stemness-associated transcription factors, SOX2, OCT4, NANOG, and if you look transcriptionally, they have upregulation of stemness-related genes. And then we took these cells and we, again, together with Dr. Cheng from BU, we did SRS microscopy to see do they have more lipids. And we found that the resistant cells were enriched in a cell population that had more lipids. And then we asked, where are these lipids coming from? So we fed the cells labeled glucose to see whether the resistant cells fed more glucose would generate through lipogenesis lipids, and they did not. Or we fed them external palmitic acid or oleic acid, also labeled. And you can see that the resistant cells have more uptake more of this palmitic acid and oleic acid. And we did this across the cell lines. And then we calculated a metabolic index that was based on the measurement of uptake of fatty acids versus uptake of fatty acids plus lipogenesis. And we found that this metabolic index correlated pretty well with the IC50 to cisplatin, suggesting that the ability of resistant cells to take up lipids from the outside was critical to maintaining this resistance phenotype. So this is true for cancer cell lines. That was easy to do, but does this hold true for patients? So we developed a protocol where we work with our GYN oncologists who collect the samples from the operating room. These were clinically annotated. The cells were taken to the laboratory, dissociated, and they were incubated with labeled glucose and fatty acids, and then they were shipped to Boston, where they did the microscopy and the analysis and calculated the metabolic index. We don't have hundreds of tumors because these are very difficult to collect, especially at Northwestern. It sounds like in other places you guys are able to collect much more tumors than we are, but we had enough samples, and we found a significant, that this metabolic index was able to predict whether the cells would be sensitive or resistant to chemotherapy. This was kind of retrospective. We knew, we followed the patients and knew whether they were gonna be resistant or sensitive. So how does this happen, and why is this important? What do the cells do with these fatty acids that they take from the outside? We measured oxygen consumption rate and found that the resistant cells had a higher OCR rate, suggesting that they probably are using these fatty acids to generate oxygen. And we then used an inhibitor of fatty acid beta oxidation, atomoxir, which blocks CPT1. And we found that atomoxir was able to increase the basal respiration ATP production and not increase, decrease basal respiration and ATP production and maximal respiration more in the resistant cells versus in the parental cells. And the resistant cells were also more sensitive to atomoxir, and the combination of carboplatin and atomoxir together blocked growth of an ovarian cancer PDX that was resistant to platinum, suggesting that this mechanism is indeed important for overcoming resistance to platinum. So we suggest that cisplatin causes increased oxidative stress that suppresses glycolysis and lipogenesis, making the cells to be dependent on uptake of fatty acids from the outside, and to use these fatty acids through a fatty acid oxidation that is necessary for cell proliferation. So I'll show you some ongoing work that's not published and is still in progress, and I welcome your input. We're moving on from this. We're also interested in cholesterol, whether cholesterol is metabolism is affected in the resistant cells. And we know that cholesterol can also be derived through import through one of the receptors, LDL, HDL, or VLDL receptor, or can be synthesized within the cell. And the cholesterol is important for membrane composition, lipid rafts, and signaling, and can also be deposited in lipid droplets. So Inu Wang, who's been leading most of the work on the resistance, measured cholesterol levels in these paired cell lines, parental versus resistant, and found that cholesterol levels measured by both Amplex Red as well as by Nile Red, which measures cholesterol in lipid droplets, was increased. And we also brought in Dr. Cheng. He did the same measurements by using SRS imaging and found also an increase in cholesterol in the cholesterol corresponding signal by SRS imaging. So we then asked, where is this cholesterol coming from? Is it being synthesized, particularly because there's some evidence in ovarian cancer that use of statins reduces the incidence of ovarian cancer and maybe improves response to chemotherapy. But surprisingly, by transcriptomic analysis, we found that the cholesterol biosynthesis pathways are decreased in the resistant cells compared to the wild type cells. And then we asked whether if the cholesterol biosynthesis is reduced, we looked also at key enzymes involved in cholesterol biosynthesis and found that in the resistant cells, this HMG-S1 and SQLE are decreased compared to the wild type cells. So this led us to think that probably there is increased cholesterol also because of uptake. So we measured uptake of cholesterol through this flow-based assay, and the experiment suggests that import of cholesterol is increased in the resistant cells. Then we looked at the expression of the HDL receptor, SRB1 receptor, and found that increased in ovarian cancer cells compared to fallopian tube cells, and particularly in the resistant cells compared to the parental cells.
This is the cholesterol added to the comfort?
This is endogenous, like just basal condition.
The uptake that we're measuring.
Yeah, this is cholesterol added, yeah.
In that experiment, you measure the uptake
of cholesterol in the resistant cells versus.
So you add cholesterol to the
free cholesterol, yeah.
What cholesterol you add?
I don't know, but I can check. And we also looked at the expression of SRB1 in primary cells from patients. And also you can see that this receptor is highly expressed. So this is another collaboration with Shad Taxton from Northwestern, who is a bioengineer, and he designed cholesterol based nanoparticles, basically by using a gold nanoparticle core that is surrounded by ApoA protein and then phospholipids. And then these nanoparticles mimic HDL cholesterol, but they actually don't contain cholesterol, but they would bind to the receptor. So we use this HDL nanoparticles, and the idea is that by using them, you kind of block the cells from taking cholesterol from the outside. And we observed that they kill cancer cells actually at quite low concentrations, nanomolar range. And the resistant cells seem to be more sensitive to the cholesterol HDL nanoparticles compared to the wild type cells. And as one would anticipate, we found that this cholesterol, these HDL nanoparticles inhibit cholesterol intake in the cells, both in the wild type as well as in the resistant. There was no significant difference. And in vivo, in a xenograft model derived from cancer cell line that's resistant to platinum, we also observed that these HDL nanoparticles lead to decreased tumor burden, not eradication of tumor burden, but decreased. So then we asked, what is the mechanism by which these HDL nanoparticles exert anti-tumor activity? We found very interestingly that the nanoparticles lead to complete depletion of GPX4. GPX4 is an anti-redox protein that's upregulated. We found it to be upregulated in resistant cells. We and others have found to be upregulated in resistant cells. And you can see here we stained tumors residual after neoadjuvant chemotherapy, and almost all of these tumors expressed high levels of GPX4. So treatment of the cancer cell lines with the HDL nanoparticles leads to depletion of this GPX4. GPX4 is an important anti-redox defense in the cell that prevents lipids from being peroxidized. And inhibition of GPX4, in the absence of GPX4, under oxidative stress, lipids are peroxidized, they go into the membrane, and they trigger a form of death called ferroptosis. And platinum-resistant cells and platinum-resistant tumors are resistant to induction of apoptosis, but they are vulnerable to induction of ferroptosis. So we measured as to whether these HDL nanoparticles induce ferroptosis, and we did this by using flow cytometry for C11 body P, which is a measure of lipid peroxides in the membrane, and found that treatment, even with very low doses of HDL nanoparticles, increases this C11 body pi, supporting the idea that this is a cell death induced by HDL nanoparticles is a ferroptosis type of cell death. Ferroptosis is dependent on iron, we used iron chelator, ferrostatin, and deferoxamine, and the viability of the cells that goes down the black boxes upon treatment with HDL nanoparticles is rescued when one of these iron chelators is used, further supporting the idea that the death induced by cholesterol import targeting is due to ferroptosis. So we're trying to figure out how this occurs, and we think that there is a link between the levels of cholesterol and the GPX4, but the mechanistic part is still kind of being sorted out. So I've shown you so far that cancer stem cells and platinum-resistant cells depend on fatty acids and lipids for survival, that lipogenesis is augmented in ovarian cancer stem cells, and lipid uptake and oxidation are increased in platinum-tolerant cells. And we have perhaps a new diagnostic test to predict sensitivity to platinum with this metabolic index, and that cancer stem cells and platinum-tolerant cells are uniquely susceptible to ferroptosis. And inhibition of lipid uptake and oxidation could eradicate these tolerant cells. How are we doing with time? I have 5 minutes. We're also interested in studying other key regulators of survivors of survival of cancer stem cells. This is a little bit different project from another student in my laboratory. We found the expression of a transcription factor FOXK2 being upregulated in cancer stem cells through a ATAC-seq-based study comparing stem cells versus non-stem cells. And this is Yachi Zhang, who also graduated last year from my laboratory. You'll see now a significant decrease in productivity because my best 2 students have graduated. And I don't have new students. So she was interested in FOXK2. She found that FOXK2 is upregulated in ALDH positive cells, both from human tumors and from cell lines, and also upregulated in tumors after neoadjuvant chemotherapy. So she asked the question, what happens if we deplete FOXK2? She finds that FOXK2 depletion leads to inhibition of these ALDH positive cells, sphere formation, and stemness markers. And cells depleted of FOXK2 also fail to initiate tumors in vivo, suggesting that FOXK2 is an important driver of stemness. But how? So she did transcriptomic analysis again, and what pathway comes at the top of the list? Unfolded protein response. So now I have 2 students working on 2 different things, both of them converging on unfolded protein response. She did ChIP-seq with FOXK2 and RNA-seq and intersected these genes that are potential direct target genes of FOXK2. About 138 genes were downregulated in FOXK2 and also were picked up on ChIP-seq, suggesting that these are direct targets of FOXK2. And among them, the top of the differentially expressed genes is ERN1, which is the gene that encodes for ERE1 alpha, the protein we've talked about in the other project. So interestingly, the peak for the binding of FOXK2 was not in a promoter region, but in intron 2, 48,000 base pairs from the transcription site. But this binding site for FOXK2 in the ERN1 gene is conserved among many cancer cell lines in the ENCODE project. And through ChIP-PCR, we also found that FOXK2 binds to this locus also in high-grade serous ovarian tumors. So to demonstrate that this is a regulatory region, we then use CRISPR-Cas9 and brought a dead Cas9 to this locus and found that the sequencing targeting this particular binding region leads to downregulation of ERN1 expression and also ChIP-PCR in the clones, these 2 clones that are located right on the binding site of FOXK2 also decreases the binding of FOXK2 to ERN1. So we talked about how ERE1 alpha, which is the protein product of ERN1, regulates ER stress. So again, looking at XBP splicing is decreased when FOXK2 is knocked down and is increased when FOXK2 is overexpressed. So how does ERE1 alpha and ER response, how is that relevant to cancer stem cells? We looked at transcriptomic analysis of ALDH CD133 positive cells and ALDH CD133 negative cells, stem cells versus non-stem cells. And interestingly, XBP, ATF6, and ATF4 regulator of UPR are among genes enriched in the stem cells. So we sorted the cells and again looked at XBP. You can see there's increased XBP in the stem cells versus non-stem cells, suggesting that the stem cells perhaps are equipped better to resist ER stress. And indeed, we induced ER stress with tunicamycin, and you can see that the non-stem cells died, 60% of non-stem cells died in response to triggering ER stress, whereas the ALDH positive cells, they were more resistant, perhaps because they have better adaptive mechanisms in response to ER stress. If you knock down XBP, however, you are able to eradicate the stem cells, decrease spheroid formation, ALDH positive cells, and all these stemness markers, and also inhibition of ERE1 alpha activity also decreases stemness characteristics as measured by sphere formation, ALDH expression, and stemness factors. And lastly, stem cells are more sensitive to inhibition to ERE1 alpha activity compared to non-stem cells, suggesting that they are more dependent on this mechanism to survive. So in all, our data suggests that FOXK2 is a transcription factor upregulated in the cancer stem cells. It directly regulates ERE1 alpha, making the cancer cells be more equipped to handle ER stress and survive. And with this, I will close by acknowledging the people who've done the work, our funding mechanisms, our collaborator. I mentioned Dr. Cheng, but also Dr. Nephew, Dr. Louis Bachman, with whom we've collaborated over the years. And also the patients from whom we got all the tumor samples and for whom we tried to do this work. Thank you.
I want to thank you for this amazing talk. It was so innovative and very inspiring. And our lab has been very interested in lipids. And just want to ask you a question about the stimulated Raman spectroscopy. So what exactly, I saw the slide, but what exactly did your lab use that for? And is it possible for me to get a tissue and on the plasma membrane of the tissue, the cells in the tissue, would I be able to use that technique to image lipids?
So we don't do the imaging. Dr. Cheng from Boston does the imaging. So he has refined this imaging to actually see various lipid, protein, cholesterol. It's very feasible in cells, fixed cells on, but it's also, I mean, I'm trying to push him to do this on tissue, like tumor tissue, because that would be really powerful to be able to measure in tissue. So yeah, I think it's uniquely suited for lipid, but I'm not an expert.
So, one more.
Yes.
So Mr. Warburg, long time ago, said that cancer cells produce too much lactate, 2 ATPs instead of 36 ATPs. So they have high lactate, lower ATP, and they have impaired oxidative stress pathway, not necessarily by decreasing antioxidants, which we have toxins from that. So my question, lactate also reduce cholesterol. It is popular, it's known. So how is it linked to your HDL receptor with lactate?
I don't know. We haven't looked at it. I mean, that's like a project that's kind of ongoing. I think that the trouble with generally metabolic targets, because this was all like very beautiful preclinical science, but bringing these inhibitors to clinic is very difficult because all these pathways are interconnected. And if you stop one pathway, you know, the cell will find another way to compensate. If you block synthesis, then the cells are going to uptake. So you have to typically use at least two inhibitors, and then it becomes very toxic also to the normal cells.
It should increase lipid synthesis.
I'm sorry?
To compensate. So the cancer cell should increase lipid synthesis.
Yeah, in our stem cell models, we show that it increases, but other people have shown, and we have shown also in these resistance cells, that they also increase uptake if there are lipids in the tumor microenvironment.
So in the cell culture, they don't need the uptake because they make it.
They make it, yeah.
So the making is up or down?
In the cancer stem cells, the making is up. In the resistant cells versus the sensitive cells, the making is down and the import is up in the resistant cells. Yes.
It was a great talk. Thank you so much for coming, and I really appreciate the time. And second question in terms of a clinical trial. So there's a lot of data about intermittent fasting and chemotherapy response and in other other disease sites, specifically breast. What is your feeling about sort of intermittent fasting and whether that is something that we will ever get to actually propose in a clinical trial design, given your data?
One of my colleagues, Jenna Marcus at Northwestern, just activated a trial of intermittent fasting for with chemotherapy in ovarian cancer. It's a pilot trial. Basically, she's trying to see whether they can achieve it. They have a way to measure like ketone production. So it's a kind of a feasibility study. I've seen data, preclinical data, and there's also some clinical data that's a little bit like older. Europeans were interested in developing this soup diet for chemotherapy. I mean, it is compelling, but I suspect it's not going to work just because there's such redundancy of the metabolic pathways. Yeah.
But I will add a little more because again, it's the heterogeneity to the tumor. The old dogma that all the cancer cells have the same metabolic.
That's true. That's another.
It's totally not true. So there are some cells who are more metabolic,
and others
are who are less metabolic. So the intervention may affect one cell and leave the other ones or the opposite.
Yeah, I think it's complicated. It's quite complicated. Our data suggests that if you eat high saturated fat, the cancer cells will die. It's like have a burger.
It's the patient diet first. I mean, that's an unhealthy
attack.
It's unhealthy.
It's great to see you. That was awesome talk. The data on the patients and looking at the metabolic rate, I think of the resistant tumors and the sensitive. I think that's really powerful. If I recall, was that only looking at glucose?
No, it's kind of a combination, because we found that the lipids are high in the cells. So we try to figure out if those lipids are synthesized, so if they come from glucose or if they come from outside. So that metabolic index is a ratio of like the import on the numerator and denominator is production plus import. So they take both into account, but the import plays more role.
The reason I was asking, I was wondering if they did any tracers, like did they look at glutamine?
We didn't look at glutamine, but we know that glutamine is important for the resistance cells.
Yes, because that's some data.
Many people are, and we're looking at that too.
Yeah, I was wondering in your models if you looked at that. I think that's some areas that I think are going to be really important.
Although those glutaminolysis inhibitors also didn't work.
Yeah, I know. I think there's there's several people that are trying to find novel inhibitors for those. So
yeah.
It's curious to see.
The effect of cholesterol incoming, whether it's from outside the cell or generated inside, how does that affect the stability of the cell or destruction?
I think it probably doesn't matter where the cholesterol is coming from, whether it's coming from the outside or from inside. I don't think it matters. And I think that if you block this receptor, we didn't do it in these cell lines, but I think Shad did it in other cell lines that are addicted to cholesterol. Some of the clear cell, renal cell carcinomas, clear cell, they are addicted to cholesterol. We tried the same strategies for clear cell ovarian cancer, but we couldn't get results in vivo at all. So I think that if you shut off the import, the cell is going to try to make more. So you could use a combination of like a statin and these HDL nanoparticles. We haven't done that yet.
So in the models where you develop cisplatin resistance, did you and eventually the cells have a better way to metabolize fatty acid? Did you ever look at the mitochondrial bioenergetics? Do you think it's a function of like an epigenetic reprogramming that supports the robustness of the mitochondria that contributes to that?
We didn't look. We didn't look.
Perhaps it's maybe with the metabolism work that you're doing, but when you're talking about fatty metabolism, I mean, that's involved with aerobic metabolism, and a lot of ovarian cancer is relatively hypoxic. Do you look at the hypoxia factor? I mean, do you look at that?
We haven't looked at HIF. Yeah,
okay.
And we haven't done work under hypoxic conditions either.
Gotcha.
Yeah, but that's a very clinically relevant question.
Yeah, I think with that, we want to thank Dr. Matei for a fantastic work. So before we go on a break, I want to call in Adam from our sponsor MassMutual to briefly talk to us. Want to come over here to the front, Adam? George, you want to put up the slide?
Thank you. I'll make it short, all right? Thank you, everybody. My name is Adam Matt with MassMutual, Great Lakes. We are out of Southfield City. We're a financial planning firm. I wanted to thank you all for allowing us to be part of today. So it's really a great honor to at least just say a small thank you to what you guys do every day. And for me to be here, you know, I graduated, by the way, from Wayne State 20 years ago from business school. So it's great to come back to this area. And for me to be here, it's an extension of what I do every day. I work with a lot of people in the medical field. So I work with them even from the time that they're residents or just started working. We help them protect their income. That's the biggest asset they have. And during the time that, during the career, so we help them out with, to keep the most or to maximize what they can keep of their income by implementing the right, tax strategies. And at the very end, so we help them at least with give the peace of mind during the term. So that's very much what I have to, and I want to thank you again. You guys do a great job to give us a good, quality of life. So we cannot thank you enough, and allowing us to be part of today's event. It's a great honor to us. Thank you so much. I look forward to working with you again and again.
Before we release you for lunch, I just want to remind everyone that we have a few posters that you can look at, and we are going to be back here at 1:30. Lunch is on the left. You know where that is. Thank you.
Now we can eat a lot because the metabolism is good. No exercise.